Ladies and gentlemen, dear colleagues, it is my great pleasure to welcome you to the Centre de Recherche Saint-Antoine for this ISTH workshop on cancer-associated thrombosis. On behalf of Sorbonne Université, INSERM, and APHP, I warmly welcome all participants, whether you are here with us in Paris or joining remotely from around the world. This workshop reflects our shared commitment to transforming scientific discoveries into better patient care by strengthening the link between research and clinical practice. I warmly congratulate Professors Anna Falanga and Grigorios Gerotziafas for bringing together such an outstanding international faculty, and I wish you all stimulating discussions, productive exchanges, and a highly successful workshop. Thank you and welcome.
Good afternoon, everyone, and thank you, Xavier, for that warm welcome. It is a real pleasure to open this ISTH partnered workshop, Cancer-Associated Thrombosis, From Evidence to Implementation, Advancing Guideline Adoption, here at the Centre de Recherche Saint-Antoine, in collaboration with CaVITE, Sorbonne Université, and ICTHIC-VAS. Let me start with why we are here today. Cancer-associated thrombosis, or CAT, is a common and serious complication of cancer. In recent years, several international societies, including ESMO, EHA, the European Myeloma Network, ASH, and ISTH, have developed evidence-based clinical practice guidelines for its prevention and treatment. And yet, despite these advances, important gaps persist between what the guidelines recommend and what actually happens in routine clinical practice. That gap between evidence and implementation is precisely the subject of today's workshop. Over the next few hours, we will hear from leading experts covering the full clinical spectrum of this problem. We will begin with patient pathways in CAT, followed by the ESMO recommendations for solid tumors, the EMN recommendations in multiple myeloma, the role of the Caprini score after cancer surgery, and, joining us remotely from the United States, Professor Corana will address cancer-associated arterial thrombosis, an area requiring much more research in the years ahead. Following the lectures, we will move into an international roundtable discussion, where we will present the results of our pre-workshop survey and open the floor to national representatives from around the world, sharing how their own countries are tackling these same challenges. I hope this will lead to a lively and constructive exchange, and perhaps by the end of the day, some concrete proposed actions we can carry forward together. I want to thank the International Organizing Committee, composed of representatives of more than 20 countries, our speakers, and all of you joining us here in Paris or connecting from abroad for making this possible. With that, let me hand over to Professor Isabelle Mahé, who will open our scientific program with a talk on patient pathways in cancer-associated thrombosis.
Hello everyone, thank you very much for inviting me to this very interesting meeting. My name is Isabelle Mahé from Paris University, France, and my topic today will focus on patient pathways in cancer-associated thrombosis, and more specifically about barriers and solutions. My disclosures. To start with a few words about context. As you know, in the past, VTE occurrence in patients with cancer was most often associated with a very poor prognosis within 6 months. Over the last 3 decades, as illustrated on this slide, the risk of mortality after CAT occurrence is decreasing over time, reflecting major advances in diagnostic and treatment strategies, even if it remains a major concern. These changes have implications for clinical practice. Patients are living longer with their cancer, thrombosis, and anticoagulants. CAT has become a chronic disease, questioning outpatients with CAT decision and management. Below are list of questions for the clinician managing patients with CAT. Where, who, what, and how with different issues about where to manage patients with CAT, community or hospital care, which healthcare professional and organization, what and which clinical situation, and for which care pathway. CAT patients management is taking place in a new multidisciplinary environment in hospitals and outpatient setting in the same way as chronic disease. The ones are involved in thrombosis care, others in cancer care, and everyday community care. Healthcare professionals have to be coordinated. In this context, a patient care pathway is being organized in addition to the cancer pathway. Patients receiving anticoagulant follow a complex treatment journey that is driven by the underlying condition, here venous thromboembolism. The specialist usually initiates anticoagulant treatment and personalize the treatment strategies. Patients with VTE, the specialist is also responsible for defining the treatment duration and reassessing the patient at different times, ideally first week, month 1, month 3, month 6, with different tasks at each visit. In practice, what is the most appropriate care pathway and treatment strategy? Beyond the initial prescription, several important aspects of care must be managed. Anticoagulant management is a dynamic and complex process involving many healthcare professionals across both hospital and community setting. And antithrombotic stewardship should focus on structuring the care pathway, improving communication between healthcare professionals, and developing shared protocols that can be used across disciplines and healthcare settings. With this idea and concept, we have conducted with the Innoviti network a multidisciplinary national and multi-society initiative to better investigate the different situations clinicians have to face with patients with CAT. You have a list on the slide. The objective was to provide practical guidance for the different situations encountered through the patient journey and facilitate a more coordinated and patient-centered approach to anticoagulant management. For the end of the topic, I will focus on some of them to illustrate the collective and collaborative work we were doing with colleagues from different specialties. For each question, we have summarized the available literature. We have been discussing the different questions and options, and then drafted some proposals. For the chapter about treatment decision, we all agreed that some points had to be taken into consideration before treatment decision. I mean, patients-related, cancer-related, VTE-related, and anti-cancer treatment-related points. What are our proposals? Of course, we have to treat, it is a strong recommendation, patients with CAT for at least 6 months, and consider different points you have listed here before deciding between 2 options, apixaban or low milligram heparin. These options come from the available phase 3 randomized controlled trials. Some situations have been pointed by mostly by oncologists, and those situations here are, for example, a non-resected urothelial or gynecological cancer, or metastasis of renal carcinoma, for example, or inoperable locally advanced breast cancer with skin involvement, a situation where it is easier to stop possible bleeding when the patient is receiving low-molecular heparin, driving the prescription to low-molecular heparin. In other situations, we can choose very safely between apixaban or low-molecular heparin, with importantly to take the advice from the patient and to reassess very periodically the decision. We are very lucky to have an orally and subcutaneous options for our patients. Of course, for extended treatment, a new clinical trial, the EPICA study, has been published last year, demonstrating that the reduced dose of apixaban is non-inferior to full dose continuation in terms of efficacy, and associated with a substantial 25% reduction in the risk of clinically relevant bleeding, leading to an update of our guidelines for the treatment option. And we have to consider the patient at 6 months in terms of VTE recurrence during the first 6 months or not, in terms of cancer. Is the cancer still active at 6 months or not? And in case of active cancer and no VTE recurrence during the first 6 months, then the treatment, the preferred treatment options should be the reduced dose of apixaban. Other situations have been considered. For example, here, different patient profile, renal impairment, low body weight, advanced age, thrombocytopenia. Some examples of our proposals. Once again, you can, of course, go back to the publication to have more information. Here, the base of our decision, and here a post-hoc analysis of phase 3 randomized clinical trials, and comparing the efficacy and safety of DOACs or dalteparin for each fragility characteristics, and as illustrated, no reason for choosing one or another option in case of fragility, leading to our proposals once again for practice. Here for renal function, in case of renal impairment, you have to assess the renal function for this patient, whatever the formula you are using, no problem with that. What is important is to consider whether the patient is renally impaired or not. And then in case of mild renal impairment, you can use full dose heparins or anti-TNA agents. Of course, in case of severe renal impairment, you have to discuss the situation with a nephrologist to make decision. For elderly patients, the same one is true. Once again, a reason to choose one or another drug, low-molecular heparin, or anti-10A agents at the usual regimen, and it is a strong proposal with an expert panel agreement. And we were also discussing, and importantly with neuro-oncologics, the situation of malignant brain tumors, which we know that could be associated with the high risk of both recurrences and bleeding. And when considering the available literature and meta-analysis, we decided, and after discussion, to propose using anticoagulant from the diagnosis, and the possibility to use anti-tynine inhibitors beyond the first week of treatment, because very few data are available for the first week of treatment. To finish with, importantly, as I was mentioning a few slides ago, we're very lucky to have an oral and subcutaneous option for treating our patients with CAT, and we have been proposing a very easy switch illustration to make it easier to move from molecular heparins to DOACs, or from DOACs to low molecular heparin in different situations that are patient dependent or procedural dependent, when you have to switch one to another. The most important that patient is receiving anticoagulant, whatever the drug, and it is important not to receive simultaneously both. We have also a chapter about the end of life and the difficult question of knowing or not, should we stop, should we continue anticoagulant at the end of life in patients receiving anticoagulant. We are working in a European project, in the Serenity project, that will provide very important data in this setting, and that will be very helpful for practice. So to finish with the illustration, and a big thank you to all contributors to this huge work we were working on last year, and that was leading to national proposals that were all published with all proposals, of course, but also data supporting our proposal. And once again, a collaborative multidisciplinary work, including specialists, GP, pharmacists, hospital, and also ambulatory colleagues. Thank you for attention.
Okay. So thank you very much for the steering committee for inviting me to this amazing meeting. I'm going to talk about ISMO guidelines, but that's not new guidelines, so we will have a very few comments about it. This is my conflict of interest. We are going to split the presentation in different points that I think that is the near future, or the future for the patients with cancer-associated thrombosis, what to do and how to make the approach. We have these guidelines. As you know, none of them are new, so we are going to say something about it. Okay, we know that the mortality in pulmonary embolism is decreasing during the year, so we are doing very well because guidelines are improving the management in patients, mainly in patients with acute pulmonary embolism. But as we know, the incidence of pulmonary embolism is increasing. It's increasing year by year, but different reasons, because the age of the patients, the population is increasing. And as you can see here, there are more patients with cancer. Patients with cancer live longer, and they receive more treatments, and those treatments imply more cancer-associated thrombosis. So mainly this increase of the VTE would be involved or be secondary to patients with cancer-associated thrombosis. Okay, we have this algorithm in patients with cancer-associated thrombosis talking about different scenarios. We have a patient, what to do in different, as Isabel says in the previous talk about, okay, what to do, when to use low molecular heparin, or when to use DOACs or any oral anticoagulants. There are some scenarios in which we can clear that we can use low molecular heparin. In the most of the scenarios, DOACs will be the choice, or we have a very good choice to have in consideration. But we need to review with our patients different clinical scenarios that are sometimes is not related to the cancer, but patients with nauseas or vomiting. Be careful, because the oral anticoagulant will be not the choice, at least at this moment, you can put in with delay at the beginning, or in this situation, you need to educate to your patients to start with low molecular heparin. There are other scenarios that we have here with its patients with renal impairment, or obese patients, or patients with thrombocytopenia. This has been commented by Isabel Mae. So my point would be about, we have a universe of questions because guidelines are good to be implemented, but the problem is that we have not all the answers. We have more questions than answers when we have specific patients in our consultant. So we are talking about different scenarios. In my case, I'm pulmonologist. My fear is about the acute pulmonary embolism. What we know about this population is in patients with cancer. What we know if this patient is in severe clinical situation, the most of them did not receive the more appropriate treatment. First of all, if we have any contraindication of anticoagulation at the beginning, please, vena cava filter is the indication, okay? And at the moment that you can restart or start again with the anticoagulation, please remove this vena cava filter. The second problem, sometimes we do not put this vena cava filter, and sometimes we put the vena cava filter and we forgot to remove it, and it's very, very important to be alert with it. And please stratify the patients. We have, this is 2019, stratification of pulmonary embolism, of the acute pulmonary embolism. We need to decide if this patient need to go to the intensive care unit or a place with a monitoring, or this patient may go home in 1 or 2 days. It depends of the risk, of the prognosis risk of these patients. Is a low risk, okay, you can go home in 1 2 days. Intermediate risk, please watch the patients. Intermediate high or high risk PE, this patient need to be in intensive care unit or in a very close monitoring. The problem in patients with cancer is that sometimes some of our colleagues in the hospital say, okay, patient with cancer, this is not going to the intensive care unit. The reason is cancer. All patients with cancer are not the same. The prognosis of the patient with cancer are not the same. And we need to improve these tools and to decide what is the best treatment for our patients with cancer-associated thrombosis. I think this point need to be guided in guidelines, in the future guidelines. Because if you have patients with a hypotensive, it implies it's a high-risk PE, these patients need to receive a fibrinolysis. Okay, move on to the guidelines. We have 2 of them, ESMO guidelines or 2019 guidelines. There is no comment about fibrinolysis in patients with cancer. Okay, if we want for ITAC recommendations, there is a comment, very interesting comment, okay? You need to analyze case by case this patient to see if this patient can receive any lysis. But if you read the reference, they are talking not about patients with pulmonary embolism. They're talking about fibrinolysis in patients with deep vein thrombosis. So it implies that we have a gap of information in this population. Moreover, if we move on to the new guidelines, for new American guidelines, there is no low, intermediate, and high risk. We have a lot of letters, okay? A, B, C, D1, D2, and for what? I don't know. D2, D2 plus R. What is the treatment? I don't know, but you have new rules with new nomenclature. So I think that they have done a very strong work, but this stratification needs to be useful for the clinician. And today we have problem to do this. About lysis, this is not only systemic lysis. We have catheter-directed therapies. There are a lot of them. The main problem is it implies subrogate outcomes that imply that it's not a very, very strong outcome in patients with pulmonary embolism. But we have very good news with HI-PEITO. HI-PEITO is the first randomized clinical trial with a very good outcome in patients with acute pulmonary embolism. This is the proposal in our hospital when we need to decide what to do in patients with a high-risk PE. Okay, systemic lysis is the answer. But if a patient has a high risk of bleeding or active bleeding, you cannot put a systemic lysis. You need to perform a thrombectomy. So very similar in patients with intermediate high risk PE. If the patients have a clinical deterioration, we need to decide what to do with them. These algorithms is made in all the hospitals with no evidence because there is no trials. As I comment, the trial is high patho trial, more than 500 patients, intermediate high risk PE that were randomized to anticoagulation or to receive catheter-directed therapy by ultrasonography, okay, facilitated by ultrasonography. But if we move on, what happened in patients with cancer-associated thrombosis? There were only 50 patients with cancer. 1 each 3 patients with acute pulmonary embolism has cancer. However, in the clinical trial, only 50 were included. So there is no data in this population to decide or what is the best way, the safety way in this group of patients. Well, we have patients that live longer. When we thought about, okay, beyond 6 months, I don't know what to do. We think that this is a patient that we need to decide to stop or to continue anticoagulant treatment, but this is not the real scenario in our consultation. Maybe this one should be the scenario. A young man in a wheelchair, probably not. This maybe is the real scenario, is a woman or 70s, 60s, in which we need to decide in a longer survival of the cancer when to stop or to continue anticoagulation. Okay, we are going to use bleeding risk scores. Oh, we have a lot of them. What this implies? Doesn't work. Okay, it's very similar to the bridge. Okay, we are going to try to decide what happened in the left is going to be the same in the right. I think that not, because it's not very easy, but it's easy to develop and score in my population. But it's very difficult that this score works in the population in other country or patients with other ages or with other cancer locations. So it's easier to develop a new score, but the problem is how works this score in our population. The most of them are not consistent in this diverse population. This is one of the several works that has been published. This is from our work, our group. More than 1,000 patients. We analyzed more than 10 bleeding scores and compare them, and 4 VTE recurrences scores. Only one of them works. It's BAT score, and it not seems very good, and only for 6 months. Beyond 6 months, we don't know. So it works only during the first 6 months, and we don't have a lot of information on this way. This is another interesting point. We ask to our database, okay, what happened with the bleeding? Are all the bleeding the same? And what we saw is that cancer locations is related to the bleeding in the 40% of the patients. That implies the bleeding will be near of the cancer location. And in the 10% of the cases, it will be near for the metastasis location. So it would be very interesting to see in the future or in other population, in other cohorts, how it works. There are here some examples. As you can see, patients with bladder cancer present hematuria, or colon cancer with lower gastrointestinal bleeding, pancreas upper gastrointestinal bleeding, or lung cancer that in patients that develop haemostasis. If you review the evidence about how do we manage this population, you have a lot of reviews by worldwide experts talking about it. In our experience, we analyzed more than 100 clinical relevant bleeding, and what we saw is that 20% of them one each 3 patients need to do something to stop the bleeding. Okay, so or an endoscopy or a bladder lavage. Sometimes we say, okay, you are anticoagulated. Okay, stop anticoagulation. No, okay, that's you are solving one of the problems. But if you have the cause of the bleeding, you can stop this bleeding. So I think that this is a very interesting point to have in consideration. Moreover, when we think that this problem was solved, nearly 1 each 5 patients, we have a second bleeding. And 6% of patients will have a VTE recurrences because we have a stop anticoagulant treatment, and in the follow-up, there's patients that are going to be a recurrence, and it has impact in quality of life. It has impact in the oncological treatment that the patient is going to receive. So we need to be very careful, and we don't know exactly how to do this. Probably we need more data in a global population to have more strong data to use in these situations. So as an example, this is what happened in the current generalized practice, in our clinical practice, and what should be in the future. The future should be similar like this, and a dynamic evaluation of the patient. Probably we need more data, not more static data. We need more dynamic data, more complex to analyze, but we need to analyze them because we know that hemoglobin at the point of the VT event, okay, they may have some role in the bleeding events in the patients, but probably it could be changed along the time. It's very similar with the creatinine or the clearance creatinine in our patients should be very, very important. We have more and more evidence about how artificial intelligence may help us in this dynamic evaluation. We need to evaluate a huge amount of data to see what happened, to see the results, apply the results, and then analyze it again. So this is a very, very good review talking about it. And our patients need more information. It's very easy today to give them some flyers with information talking, okay, you have this, you are going to be anticoagulated. If you have any of this clinical situation, you are going to have information about your disease. Because if not, we have 5 minutes, 10 minutes in our consultation, and okay, you are going fine, okay, do you have a bleeding, you have a VT recurrence, do you die? No, okay, see you at 6 months. Patients need information, and this is education for the patients and for the family of the patients. Okay, when to stop anticoagulant treatment? Isabel, may I comment something very similar to this? We think that we are very clever to decide when to stop anticoagulant treatment, but when we analyze the evidence, we don't know. This is a systematic review meta-analysis in which clinicians thought that it was the perfect point to stop anticoagulation. And VT recurrences in the first years, 28%. Okay, so in patients that we have very, very sure that is very good point to stop anticoagulant treatment. And we know that the limit is 5%. The new guidelines probably 3%, but 5%. If patients have a risk of VT recurrences higher of 5%, imply that these patients need to continue anticoagulant treatment. Okay, but what are the new anticoagulants that are very, very, okay, we have those factor 11 inhibitors are the future, are the near future. Are near or not? I don't think so. In patients with cancer-associated thrombosis, Aster and Magnolia has been stopped. This trial stopped. So we will not know if abelacimab is enough for these patients, and we need to wait the development of other drugs on this setting. And this slide is very similar to Isabel Mae. Okay, we decide when to start. The problem is when to stop anticoagulation. We have a patient in the end of life in the palliative care. There are some guidelines, some geriatric guidelines talking about the prescribing and treatments, and there is no consensus about anticoagulation. We don't know when to stop it. And on this way, Serenity Co-Clarity trial is a trial with share decisions with the patient and the clinician to decide when is the best moment to stop or to continue anticoagulant treatment. We need to wait the result of the trial on this way. Few seconds. Patients with thrombocytopenia. START trial is going to try to see is it much better transfusion with low-molecular heparin or only low-molecular heparin in patients with thrombocytopenia. We need to wait. And we have bad news with reduced trial in patients with VT recurrences. This study, it was a management study. It was not a trial in which they say how to manage patients with VT recurrences. This study need to stop recruitment because the recruitment was very low, and the results are only informative. We don't know exactly what to do with this population. So as my conclusion, first of the follow the clinical practice guidelines. This is the best, but we need to know that there's a great information. There are areas in which knowledge may be improved about catheter-directed therapies in cancer-associated thrombosis. Probably this is a very good news for patients with cancer that have an acute pulmonary embolism with high risk. Extended anticoagulation today is the rule. There is no items, there is no trials ongoing, there is no management studies. Probably we can try to do this, but today there is not. So we have APICAT, extended treatment with low intense anticoagulation maybe is the answer. What about the prescribing in end of life? We need to wait this trial, but it's a very interesting point because the family and the patients need an answer to these questions. And we have a new anticoagulant in the horizon, but we don't know still until when. And I want to finish with my team. I'm very proud of them. I think if you have a team in your hospital or between different hospitals, it's very difficult to do anything. So thank you very much.
The question then came out of the discussion at the end of together. You can.
Okay, you have any questions? If not, I want you to be paid. So
that's a question. So you mentioned the interventional treatments, trials, and studies here could be an option for some patients, yeah. But traditionally, cancer patients have been excluded from all the trials. How is it now with the new trials? You mentioned the HyPater with 50 patients only, but is this an exclusion criteria in the ongoing trials or not? Is there a focus or emphasis on this patient?
And that's a very good point. It implies there will not be any trial in patients, for example, with brain metastasis. So patients with high risk of bleeding is excluded of any of the trials. We need information about those trials. There will publish probably 5 or 6 of them in a few months where some patients with cancer will be included. But I think that in the future, we need registries or prospective studies or management studies because some of these patients will not receive nothing. Some years ago, it was anticoagulant, and if you have a brain tumor, in the 80% of the dose, not full dose, okay, minor dose because if you are suspicious, okay, maybe I have a risk of bleeding, of brain bleeding, so impossible to receive systemic lysis. This patient was in the ward. This patient does not go to the intensive care unit. Probably we need to identify in some of these patients, thrombectomy is a very good option because you are going to remove the big part of the thrombus. You are going to improve the survival because, okay, you said this is a lung cancer stage 4. Okay, what is the survival? 1 year? Pulmonary embolism is going to kill him in 1 day. If this is a high risk PE. But you need to do this balance. And sometimes when you have, okay, it's a patient with cancer, it's just the same sarcoma or breast cancer with hormotherapy. We need to see what is the difference in the global scenario in patients with cancer-associated thrombosis. And probably guidelines need to afford this topic. Yeah.
And define during the screen test what is the patient and then we can put it pulmonary embolism, which is completely asymptomatic. And the guidelines propose wait 4 weeks before doing the operation. But very frequently we have this discussion with the clinicians and anesthetists with the neurologists in order to find the time to do this operation. We would think that we can wait So somebody with has already embolism probably before the screen test to do the operation and start the treatment with anticoagulants after the operation or to retard the operation.
So that's tricky questions. The main point is we know patients with pulmonary embolism, if symptomatic or incidental, survival is the same. First point. Second point, if you have to perform a surgery, you are going to imply more pro-thrombotic situation. So the balance should be, what is the most severe situation? We have a very good relationship with the gynecological department. There are some mass that need to be, the surgery need to be soon than later. Then in those patients, we propose vena cava filter and scar anticoagulation, vena cava filter, surgery, low molecular heparin, and then we remove this vena cava filter. This is the approach in this clinical situation. There are others that decide, okay, I'm going to plan the surgery in 3 weeks, but for me, it's the same 1 month. In my case, as pulmonologists, we analyze, for example, the lung cancer. It depends on the stage, because if you wait, the stage may be worse. So what is the balance? So in our hospital, more and more, we are more intense to try to put vena cava filter surgery and then anticoagulation, vena cava filter surgery, then anticoagulation, and then remove the vena cava filter. No, 1 month, 1 month. Yeah, the patients recover from the surgery, go home. We saw the patient in our consultation 1 month after the surgery, after the discharge of the hospital, and we see if it's very good with low molecular heparin with no problem. Then we plan the removal of the vena cava filter. 6 months is too much. You know, 1 month. Yeah. Now we need to be sure that this patient can be anticoagulated in the full dose, because if not, this patient is going to be continue with this vena cava filter. Now we maintain less than 10% of the patients with vena cava filter in this clinical situation. The most of them, we put them and we remove them. Thank you very much.
Rationale for the management of venous thromboembolism in patients with multiple myeloma. So the first element that we must keep in mind is that by the time our patients live longer, because oncology is making essential progress, and on the other side, the longer they live, they accumulate more risk factors for venous thromboembolism, and the cancer itself is becoming a long-lasting chronic disease, meaning that procedures that cancer cells are not absent, but they are still present. So by the time what the data say is that the number of events, of thromboembolic events, are going to increase, either in the symptomatic or the asymptomatic form. So all these questions that we are facing today, it is expected that will be magnified in the near future. And another thing that we have also in mind is that by the time, since the cancer is present, is diagnosed, or even some months before the diagnosis of the cancer, the risk of thrombosis becomes almost constitutional. You can see here that compared to the baseline reference risk in the general population, the patients at the day of the diagnosis of the cancer, they have a high risk of thrombosis, which rises up to 18 folds compared to the similar persons without cancer. And in the first 6 months when the treatment starts, the risk can be multiplied even by 20 times or higher, depending again on the type of the cancer and the other individual characteristic of the patients. And this risk persists even when the disease is considered to be in remission. This is number one. Number two, about up to 10%, from 4 to 10% of the patients with idiopathic VTE, when we are doing the necessary exploration to identify the cause of idiopathic VTE, we discover cancer. So from this point of view, venous thromboembolism becomes a clinical sign of the oncological disease. It is not just an accident. And the third is that the new treatments that we use, which are extremely efficacious or very promising in the cancer, like the targeted therapies and so on, they are associated also with an inherently risk, which is treatment related. So this is the context into which we will move in the next year. And of course, we should not forget that each event of venous thromboembolism is beyond the impact of on the quality of life or even the life of the patients, has a cost for the healthcare system. It is calculated to be about 10 to 15,000 euros per event. And there are some data which are very impressive, is that from the total budget in the European Union, which goes up to about 13 billion euros per year, almost the half is given to treat cancer-associated thrombosis. So from the 12 billion of euros that are given for the treatment of thrombosis, half is given for cancer-associated thrombosis. And the cancer patients represent just a part of the total population that gets is presenting thrombosis. So you understand the impact of venous thromboembolism in the healthcare systems, which is not very important. So in order to understand and to put in place the concept of the cancer-associated thrombosis, we must come back to the elementary knowledge, Virchow, the triad of Virchow. Here it is not necessary to analyze it, but what we know today is that we know the first guilty for cancer-associated thrombosis, and this is the cancer cell, which is covered by fibrin. And this is a very nice photo that our PhD student Mohammed Baghdadi took here. So this is the fiber which is organized as a shield around the cancer cell. From the one side, this is the documentation of the prothrombotic capacity of the cancer cell, and from the other side, imagine that you use a targeted treatment in order to kill this cell, which is very well hidden behind this fibrin network. And we know it is very complicated, all the mechanistics that exist, that we know that beyond activation of coagulation, cancer cells, by releasing microparticles and extracellular vesicles, they can also activate endothelium. So the cancer can induce also endotheliopathy. And this is another concept that we must keep in mind, in addition to hypercoagulability, netosis, and so on. And this is an activity, endotheliopathy, activation of endothelial cells, that is induced also by myeloma cells through the extracellular vesicles that they release by the myeloma cells. And also the myeloma cells, they can activate blood coagulation in a similar manner, but not in the same strength as solid cancer. You understand? So that what Professor Palomares was saying in the beginning about the connection of solid cancer and venous thromboembolic risk, it can apply, at least from the mechanistical point of view, in the patients with myeloma. And of course, we know that there are many somatic mutations to cancer cells that determine the risk of thrombosis. So each cancer cell or each type of cancer has its own fingerprint, personal ID, prothrombotic ID. And among these mutations, you will find some mutations which are also hematological mutations. And if we want to see the fingerprint, the procoagulant fingerprint of the myeloma cells, or in myeloma patients, when we are measuring the day zero, the day of diagnosis, before any kind of treatment administration, the biomarkers of hypercoagulability, we see in these patients high levels of thrombin generation, high levels of tissue factor in the blood, high levels of extracellular microparticles which are coming from endothelial cells and platelets, high levels of P-selectin and E-selectin, meaning endothelial cell activation, and also alterations of thrombin generation process that are mandatory of endothelial cell activation and decrease procoagulant phospholipid-dependent clotting time, meaning that the patient is at the beginning in a hypercoagulable state and in a kind of endotheliopathy. And when we see the evolution of venous thromboembolic events in patients with myeloma compared to patients with lung adenocarcinoma from the day zero of diagnosis and afterwards for 1 year. This is a prospective studies with a similar design in myeloma and in adenocarcinoma. What we see, the same image. In the first 6 months is the window where the risk is higher. And in the first 6 months after the diagnosis, the primo diagnosis, or even some newer data show the diagnosis of the recurrence. And this, in patients with myeloma, there is a second group that appears to be manifested after the 12 months, and is there where the new treatments are started to be applied, and the new target treatments are given to the patients. And when we are playing with the statistics in order to predict who is going to do thrombosis, the same markers are becoming clinically relevant, both for myeloma and from Hypercan, which was done in Italy. The markers of hypercoagulability are predictors. It's like the thermometer that we are giving to our patients in order to measure the temperature and to say, yes, it's an infection with, probably there is an infection. This is the biomarker in the case of, the value of biomarkers in the case of cancer. So we know the first guilty, and we have to understand what is making cut beyond the first detail. And in myeloma now starts in a new discussion in the plasma cell dyscrasias about the role of the immunoglobulins and the monoclonal gammopathy. So we have an increasing amount of evidence showing that patients with monoclonal gammopathy of undetermined significance is probably a new cause of thrombosis in patients with plasma dyscrasias. And this is the same finding for many different studies that show that patients with MGUS are patients with an inherent risk factor, meaning that we should reevaluate probably all the problematic that we have behind the exploration of, let's say, acquired thrombophilia, and we should induce the research of monoclonal gammopathy of undetermined significance in some specific, particularly elderly population for the risk evaluation of venous thromboembolism. And let's now move to the most modern part of the myeloma era, which is the new treatments of myeloma, the targeted treatments. And with the targeted treatments, we learned that first, the historical model of the targeted treatments was thalidomide, which is associated with a moderate increase of risk of venous thromboembolism, about 3%, 6% of the treated patients. And we started to get a signal of arterial thrombosis also. And then we realized that when thalidomide is combined with dexamethasone, the risk is increased by about 2 to 3 times. And also the signal for arterial thrombosis also is increasing. And the more we are moving to the newer therapies, like the proteasome inhibitors, the risk of venous thromboembolism persists to be high, and also the risk of arterial thrombosis emerges in about two-fold higher level, 2-fold higher as compared to the patients who do not receive the newer treatment with the proteasome inhibitors. So something is happening, and venous thromboembolism starts to appear as a new condition in myeloma together with arterial thrombosis. And when we are doing the classification of the different treatments according to the risk of venous thromboembolism that they induce, you can see that there is a huge variability. So this means that the physician that Professor Palomares mentioned previously that has to evaluate the risk of thrombosis, he has to take into consideration many factors, even the details of the treatment that he is going to apply already when he is in a difficult situation to decide which is the best treatment in order to fight myeloma. If we choose lenalidomide or thalidomide or proteasome inhibitors, and imagine how a clinician could handle this problem if you ask him to choose in the basis also of the risk of venous thromboembolism induced by his treatment. And there is something even more surprising and important. When we compare the new treatments, the targeted anti-cancer treatments, the immunotherapies, regarding the venous thromboembolic risk that they induce, and we compare with the classic conventional chemotherapy, we see that the increase of the thrombotic risk is about 2 to 3 folds. So beyond the cancer-associated thrombosis per se, now we are moving in a new era with the new drugs, which is also thrombosis induced by some kind of the treatments in a field which is pro-thrombotic by the cancer per se. So you understand that the life of the oncologist becomes much more complicated if we convince him that your thrombosis is a very important problem. And we have to convince him that thrombosis is an important problem. Why? Very simple reason. Because the patients who develop venous thromboembolism, they have higher probability to die. And this is these are the data from prospective studies with the patients treated with immunotherapy. Those who developed cancer-associated thrombosis, they had about 2.5 folds higher risk to die as compared to those who did not. So meaning that either thrombosis is a sign of a more aggressive disease, or thrombosis deteriorate an unstable status of the patients that become even more vulnerable. And in the new treatments, the new strategies that CAR T-cell represent, the problem did not disappear, even if we consider that the CAR T-cell therapies might eradicate the cancer, and particularly the myeloma or the lymphoma, the hematological cancers. Because what it was shown by the meta-analysis that our colleague and the good friend Pedro Las Casas did, is that in the clinical trials where CAR T-cells were employed, and where venous thromboprophylaxis was systematically given by the centers that they applied this, participate in these studies, the signal of venous thromboembolism was extremely low. And the question is it low because thromboprophylaxis is applied, or is it low because CAR T-cells eradicate the myeloma cells? And the signal we have is that from the analysis from the real world studies is that apparently the explanation is the first one. It is not because cancer disappears. In addition, CAR T-cell treatment induces a very huge inflammatory reaction, but it is because the academic centers that participate in phase 3 trials applied thromboprophylaxis according to the recommendation. When the real world trials studies are coming, they show that there is an increase of about 1.8 times, although it is underestimated, of the number of the symptomatic venous thromboembolic events in the real world. And what we know is the real world does not apply thromboprophylaxis in oncology. Only 10% of oncological patients receive thromboprophylaxis. This means that even with the more revolutionary treatments against myeloma, the signal of venous thromboembolism and the risk of venous thromboembolism does not depend on the efficacy of the treatment, but depends on the initiative of the physician to evaluate the risk and to prescribe thromboprophylaxis. And then we are in the recommendations what we say that do the risk assessment and use one risk assessment model, but the IMPET-VT risk assessment model. But if you ask the clinician to decide which are the parameters that he must introduce in his equations, he will never do. And if you consider that this kind of recommendations is 1A, and you will give him the instruction, the recommendation, or her, to do the risk assessment model using the IMPET score, which is the best of all, with a c-value 0.6, this means that the probability, like Pilufas with the coin, is about 60% to get the correct answer. This is not medicine. This is something between my feeling, my chance, and the difficulty that we introduce to the real life physician, not to us, to the expert, let's say. But based on this concept, today the recommendations are clear. First, educate the patients with all the problems that Luis said before. Second, evaluate the bleeding risk of the patients, because this is an obstacle. This is an obstacle for the application of pharmacological thromboprophylaxis. Third, evaluate the type of the anti-myeloma treatment, because if the patient is going to receive carfilzomib, in this case, the strategy is different as compared to those who are going to receive thalidomide and so on. And then you have to evaluate the renal function, and you have to evaluate the platelet count, and you have also to evaluate the adherence of the patient to the treatment, and also you have to evaluate the fear of the patient, because the patient that receives the diagnosis of multiple myeloma, what is going to do as a first reaction? Google, where he will see that he has a blood cancer. So he will say, or she will say, I'm going to die. And he is coming to me, and I'm going to tell him that, you are in the race to get a venous thromboembolism, pulmonary embolism, and you are in the race to die. This is the reality. And then I will say to him, I will start to give you some injections in order to not to die, because you will have a pulmonary embolism. And how this patient will react, nobody knows. And we are completely inexperienced to these questions, to handle these questions, because we do not know even our psychological status about these problems. So you understand that we apply the thromboprophylaxis, which is a low molecular weight heparin, so apixaban 2.5 milligrams twice daily, or Xarelto 2 milligrams. And how, for which duration? We say that three months. 3 months is grade 1B, so it is not obligatory. And if you imagine that the doctor has a fear of the bleeding, and he is exerting medicine not in Paris, but in Montargis, in 200 kilometers from Paris, where the access to the hospital is very complicated, he will be he will not be enthusiastic to apply our recommendations. And the same will be in the treatment scenario. The treatment scenario, the things is also easy. We have a low molecular weight heparin, so DOACs before starting or not with low molecular weight heparins according to the situation. And the concept for the treatment is the same that for myeloma is the same as that Professor Palomares developed for the solid cancers. But the limitations of the treatments are again the same. And we had the good data from the APICAT study that showed that when we are doing extensive treatment with 2.5 milligrams beyond the 6 months, 2.5 milligrams of apixaban beyond the 6 months of the first phase of treatment, the efficacy is the same, and we protect our patients from bleeding. But the ad hoc analysis of APICAT showed that the bleeding exists. Not so much, but my patient who was in Montargis last month, and he was agricultural, and he did a wrong movement in his job. He came with a femoral hematoma in apixaban 2.5 milligrams. It is not the problem of the apixaban in this case. It is my problem. I was not a good doctor. Why I was not a good doctor? Because I did not educate correctly my patient. And another patient that I had, where in these documents that, as Professor Palomares said, that we describe if you have some blood in the urines and in the feces and so on, go to your physician. I had a patient who came on apixaban for myeloma, 2.5 milligram, and he came and he said, I was hospitalized for one week because the hematocrit was 7, and he was transfused. And he found that he had a gastrointestinal bleeding. But the problem was, I said, but I wrote in the paper, I wrote, if you had blood in the stools, you must go to the hospital. He said, no, I didn't have blood in the stool. My stools were black. Okay, my stools were black means that this patient did not understand what, no, he understood very well everything, but I gave a wrong message in my paper. I didn't describe in my paper, go to the doctor, to the general practitioner, if the stools are black. I said in my paper, go if you see blood in your face. This is the reality. So in this reality, we introduce even more parameters, which are the particular situations, what we are doing to the obese or fragile patients, and what we are doing in severe renal insufficiency and so on. This is clearly written. The same line is in multiple myeloma, and the same line is the solid cancer. And the answer behind this, because we have the same people who wrote the same these two documents, and we read the same books. And if we wanted so to get a message from this peripheral, is that we have to apply the guidelines. But my problem today is not how to apply the guidelines in Saint-Antoine Hospital in the hematology department. Our problem is how the patient who is leaving the hematology department of the Saint-Antoine Hospital and goes to Montargis or to the village far away from this small town will continue to get the anticoagulant treatment by a general practitioner who is overcharged, a general practitioner who cannot find the experts here because we are overbooked also, and then a general practitioner who is doing in the same time many different works. So this is a concept that we have developed about 10 years ago with setting up specific consultations here. The Cotton Club, as I used to say, the Consultation Thrombose and Oncology, and also associated with the master program for the thrombosis and cancer. And now the question is how we can move to the next generation, as Professor Palomares said, for the use of artificial intelligence and the electronic decision support tools in a concept like the Spider-Man, in a center connected with the tissue, with the network in the periphery, because our fight is not the hospital. Our fight is into the community, into the general, in the primary healthcare structure, in the frame of the public health system. Thank you very much.
I think, Grigorios, that the discussion goes directly to the end with the round table, and then on sake of time, we can move to the presentation of Professor Caprini about the surgical oncology.
It's Professor Caprini.
I don't know how to manage.
Mohammed, can he's not on late, Professor Caprini. So we will put the video.
Greetings, everyone. It's a great pleasure to come to you today. And I want to begin by saying that you see I'm wearing a shirt that says, "Never treat a stranger, never kill a friend." And the importance of this, and we try to promote this around the world, is question your patients before you operate on them so you know what their risk factors are so that you can protect them depending on what their various risks are. And don't forget, the risks for surgery are not only the type of procedure, but also the baggage that the patient brings to the emergency room. So with that having been said, I'd like to talk about VTE risk after surgery, the role of the Caprini risk assessment model, especially with reference to the cancer patients. I have no disclosures related to this presentation. And the Caprini risk assessment model is the most validated tool in surgical patients with 40 risk factors. And it has been massively validated recently by Thomas Orbanek and Kiri Lobostov in 4.2 million patients from around the world. And what's really important is the Caprini score isn't just a list of risk factors. It also compares the power of the risk factor plus the number. So take a look at patient A, 42-year-old patient with a BMI of 29 and on birth control pills. A score of 3 with 3 risk factors. The second patient is a 76-year-old patient with a history of pulmonary embolus and a past cancer. 3 risk factors, but the Caprini score is 8. So although each of these patients has 3 risk factors, the combination of number of risk factors and their power results in a more accurate estimate of VTE risk compared to a simple list of risk factors alone. You wouldn't give prophylaxis to a person with 3 risk factors with a Caprini score of 3, but you better do it for a Caprini score of 8. Now, the Caprini score thresholds vary, and these are based on these 4,200,000 patients. And you can see, originally, Chess said that everybody above 5 was high risk, but we know now that there's a very large group of individuals and over 5, depending on their risk, that have greatly increasing chances of developing cancer with an increasing score, as you can see, all the way up to 47% when the score is over 11 to 12. Now, there's a problem with the VTE after cancer surgery, and 2.3% after oncologic surgery associated with a 6-fold increase in mortality. And most VTE events occur after the patients go home from the hospital. And if you take a look here at the percentages, depending on the type of cancer, also will be the incidence of VTE. Cancer guidelines, it's recommended for high-risk patients. These are patients with pancreatic, liver, biliary, lung, stomach, brain, and esophageal cancer, and moderate risk. You can see here colorectal, ovarian, uterine, bladder, and renal. And then the lower risk are prostate, breast, and head and neck. And pharmacologic prophylaxis was recommended for all cancer patients except for basal and squamous cell skin cancer. And low molecular weight heparin is the preferred prophylactic agent, and using mechanical prophylaxis as an adjunct, especially when pharmacologic prophylaxis is contraindicated. And incidentally, every patient on the operating table, except for certain orthopedic exceptions where you're operating on that leg, should have compression, because the operative environment, including anesthesia, is a perfect milieu for the development of thrombosis with all 3 of Virchow's factors present: stasis, hypercoagulability, and vascular damage due to dilatation and stasis. And so pneumatic compression means to be used during the operative procedures, and of course post-operatively. Taking a look at the various incidents of cancer surgery and the Caprini validation, you can see the cutoffs here in colorectal, and there's no question that if you combine D-dimer with the Caprini score, it increases the accuracy. We'll see more about that later, and you can see the other figures here. Esophagectomy, particularly high incidence of cancer, and as well as thoracic and GI. This family history is the single most important missing element in histories and physicals, and one of the most powerful risk factors that can lead to a thrombosis. And it's good. It has to be looked at in all 3 models. And this study from thrombosis haemostasis in 2013, in 183,000 individuals, it showed an elevated familiar VTE risk persisting across degrees of relation, not only first degree, but second degree, third degree, and even sometimes people that live together because they might have similar lifestyles. And so that study's been ignored in the literature. But then along comes Zoller in 2024 and shows a study in 750,000 patients showing the distinct clusters depending on the degree of family history of association with the patient, first degree, second degree, and so forth. 8 different clusters that are associated with not only venous thromboembolism, but other complications as well. Obesity, diabetes, gout, varicose veins, and arterial thrombosis. Very important. Don't forget VTE family history. Yes, it's fine to talk about thrombophilias, but thrombophilia only 30% of people that have a clot have a positive marker or have been measured. So you've got to have the history of family. Family history is very, very important. Another thing that's often overlooked, and this is the only risk assessment that has this question in it, and it's very, very important. Patients that have had unexplained stillborns, recurrent spontaneous abortions, premature birth with toxemia, growth-restricted infant, these patients may carry one of three important antiphospholipid antibody genes, lupus anticoagulant, anticardiolipin antibodies, or beta-2 glycoprotein. If they have all three, then the chance is very high that they will develop a venous thrombosis. And don't forget, sometimes after the pregnant years in a woman, sometimes these defects may persist. And so you've got to always ask these questions. And if they're positive with this history, test them. Antiphospholipid antibodies is a simple test. There is no question that the Caprini score needs more work, failed to moderate discrimination, and some of the patients, and this study is interesting, it says that 70% of colorectal patients did not have a high Caprini score. But in my opinion, if you go back and look at those studies, you'll find that a lot of Caprini score studies, they don't look at all 40 factors. So when they don't look at all of those factors and the obstetrical factors, and the family history is most often not looked at, then of course, you're not going to get an accurate Caprini score. And that's really very important. Now, adding the D-dimer, as you can see here in this table, it shows that that will increase the incidence, increase the accuracy of the Caprini score. The Carana score versus the Caprini score, of course, you can see the differences here. One of the things I'd like to see done going forward is to test the Caprini score in ambulatory surgery patients, because I don't think it's a stretch to consider that 40 factors, when asked in these patients, will be better than 5 variables. But that's an area for improvement for some of my younger investigators to thoroughly flush out. So don't forget dynamic scoring. There's an initial assessment when the patient comes into the hospital, but following that, it's important as the patient goes through the hospitalization, as things change, as new diagnoses come up, infection and so on and so forth, unsuspected cancer. You've got to add those. And then very, very important at discharge to reassess the patient to see which patients need ongoing prophylaxis after hospital discharge. Studies indicate only 30 to 40% of eligible cancer patients actually receive extended prophylaxis, and this creates a significant gap in care. Ask every question. Complete history taking is non-negotiable. Don't forget, never treat a stranger, never kill a friend. You've got to ask all the questions, and when you know those, of course, you'll protect the patient. Mandatory implementation of evidence-based VTE prophylaxis, in my mind, is one of the biggest missing elements. It's fine to have an algorithm that indicates what to do, but unless it's consistently applied, it's not going to be effective. And there are many nudges to use to help doctors encourage them to do these results, whether it's with peer pressure, whether it's economic incentives, as was done in England at one time. There's various ways to use nudges to get this task done. So, and finally, and thank you very much. I appreciate listening to this lecture, and I'll be happy during the question and answer session to answer any questions. Thank you very much, and I hope you have a wonderful meeting.
And now we are moving to our next speaker. It will be Alok Khorana. Professor Khorana, as you know, is the person that there is an expression, an old expression, that says that the ice is broken and the road is open. So it's this one who has broken the ice, because we followed with the other versions of the scores and so on. But it's the Khorana score that opened all this discussion today about cancer-associated thrombosis and the risk of cancer-associated thrombosis, because in fact we must be accurate. Cancer-associated thrombosis started because of Falanga. And I think that we have to appreciate particularly the contribution of Anna Falanga in this new chapter of medicine. So my colleagues will give me the method to pass to the person who has broken the ice, and we followed afterwards. And now he is going to present a new dimension of cancer-associated thrombosis, which is the cancer-associated arterial thrombosis, the ARTCAT.
Hi, good afternoon. Can you hear me? Can you hear me?
Yes.
Okay, perfect. So thank you very much for the kind introduction, and thank you for inviting me to discuss this subject today. It's cancer-associated arterial thrombosis. It's a little bit different than what we've been talking about here, which has been mostly venous thromboembolism. But as those of you who take care of people with cancer know, arterial thromboembolism is also very common. And we often think of venous thromboembolism as part of Trousseau's syndrome. But what if Trousseau had a stroke instead of a DVT? And I think we need to sort of expand our understanding or perception of Trousseau syndrome to also include arterial events. Just like venous thromboembolism, arterial events also precede the cancer diagnosis and occur after the cancer diagnosis. So these are data from a really interesting study by Navi and colleagues published in Blood about 7 years ago, looking at rates of stroke and MI and peripheral arterial embolism occurring before the cancer was diagnosed by 30-day intervals. And as you can see, for up to almost a year before, the rate is about 1% or so. And then just a few.
Alok, excuse me for the interruption. You have to stop and share again the screen because we do not see the slides here.
You don't see the slides here. Okay.
You share again.
Yeah, let me try here.
This. Yes. So you will do it again.
Yep, hang on 1 second.
Teams is more complicated than Zoom.
Okay, can you see them now?
Yes. Yes.
Okay, perfect.
Thank you very much.
No, of course. Okay, so this is the graph I was referring to, which is looking at the rates of arterial events preceding a cancer diagnosis by 30-day intervals. And as you can see, just a few months before the cancer diagnosis, the rates of arterial events start to go up and they peak immediately before the diagnosis of cancer. So this is actually very similar to presentation of DVT or PE, and then the cancer diagnosis occurs, but you can also see it with arterial events. You can see a stroke or an MI, and that can lead to a cancer diagnosis. There is, of course, also an increased risk of arterial events after a cancer diagnosis. This is also by Navi and colleagues from a couple of years prior to that study, looking at rates of arterial events. And as you can see, the rates are actually very high. They're in the range of 3, 4, 5% after a diagnosis of cancer. And the rates are higher with a higher stage. So stage 4 cancer patients have the highest rate. So the pattern here is very similar to venous thromboembolism. The rates start rising before a cancer diagnosis, the peak at the time and immediately after a cancer diagnosis, can persist for several months up to years, and are higher with a more advanced stage. So for today's discussion, I wanted to focus mostly on new data. So new data regarding the epidemiology of arterial thromboembolism, its presentation, its management, and where we are headed next in terms of future directions and emerging treatments. So let's start with what's new in epidemiology. I think we have a better handle now on the rates of arterial thromboembolism. These are data from a very large meta-analysis published by Deng and colleagues last year. looking at rates of both arterial and venous events across over 5 million patients with cancer. So this included 74 studies, long duration, very high sample size. And I think this provides sort of a benchmark of what are the actual rates. And yes, the rates of venous thromboembolism are high at 26 per 1,000 person years, but the rates of arterial events are also pretty substantial at 11.6 per 1,000 patient years. And so I think this study provides sort of a baseline estimate of where things stand right now in 2026 in terms of rates of arterial events in people with cancer as contrasted to rates with venous events. We also have a lot of data now on risk factors for cancer-associated arterial thromboembolism. These include cancer-related factors, and I'm going to show some of these on the next few slides, but this, again, are similar to what we see with venous events. So the primary site of cancer, the stage of cancer, the initial period after diagnosis, several treatment-related risk factors, including systemic therapy, the use of drugs like cisplatin, but also many of the newer drugs. You heard just a little bit earlier about CAR T therapies, but immunotherapy is very commonly used in both solid tumors and liquid tumors. And immune checkpoint inhibitors, targeted therapies such as anti-VEGF and anti-EGFR therapy are also strongly associated. And there's a bunch of candidate biomarkers that are being studied: genomic, tissue factor, D-dimer, platelet activation markers, and inflammatory markers. And so a lot of activity in this area, and hopefully we'll learn more about this over the next couple of years. Just sort of mapping this risk across different sites of cancer. So the three most common presentations of arterial events in cancer are acute coronary syndrome, ischemic stroke, and peripheral arterial disease. And these rates are different across different types of cancers. So coronary events have the highest rate in people with lung cancer. Kidney cancer patients have the highest rate of peripheral arterial disease, although it's also very common in pancreatic cancer. And then people with brain tumors have a very, very high rate of ischemic stroke and not so much of acute coronary syndrome. So even the arterial thromboembolism is common across all these different types of cancers. The rates of specific events varies by the type of cancer. And I think that's one important thing to keep in mind in terms of risk. Genomics may play a role. These are data from the Sloan Kettering data set, looking at a large number of people with cancer that were treated at Sloan Kettering in New York City. Sloan has their own genomic data set called the MSK Impact. So their next generation sequencing is done in-house. And they were able to connect those genomic findings with rates of arterial events using the electronic medical record. And mapping these different oncogenes and tumor suppressor genes across close to 12,000 adult cancer patients. These were people who had no prior arterial events, and adjusting for sort of age and type of cancer, cancer treatment, stage of disease, and so on. They were able to identify two genes, STK11 and KRAS, that were associated with a higher risk of arterial events. Very high for STK11, 2.5-fold increase, with KRAS also pretty high, 2-fold increased risk of thrombosis. Now, is that driven by the oncogene or by the type of treatment? As we'll see in the next couple of slides, the type of treatment can also make a difference. These are rates of arterial events with immune checkpoint inhibitor therapy. This is data from a single institution study, but there are several other data sets like this across different institutions. And all of them show the same thing, which is that people with cancer that receive immune checkpoint inhibitor therapy have a higher rate of arterial events. And you can see this is true if you look at all cardiovascular events, as shown here in panel A, a 4-fold increase. If you look at just MI, hazard ratio of 7 for immune checkpoint inhibitors, coronary revascularization, or ischemic stroke, all are elevated across the board for people with receiving immune checkpoint inhibitors. Probably a very interesting sub-study of this was looking at plaque progression. So they were able to capture images of plaques in a small subgroup of people with this that were receiving immune checkpoint inhibitor therapy. And they found that not only was there a 3-fold increase in arterial events, but also total plaque volume increased by 3-fold, with 2.1% per year progression before immune checkpoint inhibitor therapy to 6.7% per year after. Again, small single institution, but suggesting that either the inflammation caused by immune checkpoint inhibitor therapy or the inflammatory cytokines that are released, something is changing anatomically, plaques in arterial vasculature and leading to all of these different events that are increasing. Targeted therapy also is associated with an increased risk of arterial thromboembolism. These are data by Mike and colleagues looking at ICI therapy, but also VEGF targeted therapy, multikinase inhibitors, and EGFR target therapy. And as you can see across the board, all of these drugs have an increased risk of arterial thromboembolism with the use of targeted agents as compared to chemotherapy alone, which used to be the standard in prior cases. So increased risk with this as well. I won't go through sort of the whole list, but just know that there are several different classes of drugs that are associated with the risk of arterial thromboembolism. They can include hormonal therapy like tamoxifen, anti-VEGF antibodies like bevacizumab, TKIs that target VEGF such as sorafenib and sunitinib. We talked already about the EGFR and ICIs, and then ibrutinib, which is a drug commonly used in lymphoma, is strongly associated with an increased risk of atrial fibrillation, which can lead to an increased risk of stroke. Are there ways to identify high-risk patients for arterial thrombosis? We don't quite know that yet. There's at least one risk assessment tool that has been published that's shown here that captures some cancer characteristics such as the stage, but also other patient characteristics such as age, history of hypertension, atrial fibrillation, and some biomarkers such as the neutrophil to lymphocyte ratio and the D-dimer. This has been tested in a large study population. Hopefully, we'll have more prospective validation of this risk tool in the recent coming years. There are other risk tools in development. We had one presented at ICTHIC just a couple of months ago, and hopefully we'll have a paper on that very soon as well. Okay. Moving on to presentation and management. So I discussed sort of that there are three sort of ways of presenting. One is, of course, heart incidence, so acute coronary syndromes. 2 to 4-fold increase is seen in cancer patients compared to the general populations, much more common in lung cancer. Increased risk of stroke rate is somewhere between 1 to 5%, again, higher in lung cancer patients. Highest risk is around 3 months after diagnosis, decreases over time, generally no longer detectable beyond 1 year, but patients who have one ischemic stroke are at a high risk of second ischemic stroke as well. And then all of these events, arterial events, are associated with the worsening of survival independent of metastatic progression. Peripheral arterial disease, about 25% of reported peripheral arterial events actually occur in people with cancer. Lung, brain, and kidney cancers have the highest risk, greater risk of amputation, greater risk of mortality, greater risk of recurrence. So again, similar to venous events, these outcomes are bad. They're associated with bad outcomes, and they're associated with bad rate of recurrent disease. How can we prevent them? There's two approaches that could be used right now. One is statin therapy. And we typically think of statins as drugs that reduce risk of arterial events sort of independent of thrombosis. But in fact, there is data to suggest that even in a very hypercoagulable state like cancer, statins can reduce the risk of thromboembolic events. These are data from a large analysis that was published in Thrombosis Research 2 years ago. Close to 500,000 newly diagnosed cancer patients followed for about 4 years. Testing to see, this is not randomized, this is a nested case control study. So people are on statin for different reasons, and they were studied to see if you were on a statin, was there less chance of getting a blood clot? And statins were associated with a 30% reduction of thromboembolic events, including arterial events, where the adjusted odds ratio was 0.68. So very interesting data suggesting that if the cancer patient already has an indication for a statin, you should keep them on it or add them to the medication list if not already on it, because it can reduce thrombotic outcomes in this population. What about primary prevention with DOACs, which are successful in preventing VTE? We don't really have great data. The 2 large studies of DOACs primary prevention looked at apixaban and rivaroxaban. The apixaban study, AVERT, did not capture arterial events as a secondary endpoint, so we don't have any data from AVERT. From Cassini, we had a very few number of patients that developed arterial events, 4 out of 400 patients in the rivaroxaban arm. compared to 7 out of 400 patients in the placebo arm. So 1.7% down to 1%, obviously not powered to look at sort of statistical significance, but suggesting that DOACs would be helpful in preventing not just venous events, but also arterial events. A very sort of different syndrome is atrial fibrillation, which by itself, can affect outcomes in people with or without cancer. But active cancer is actually independently associated with an increased risk of atrial fibrillation. And of course, having AFib increases the risk of systemic thromboembolism or stroke. But because most people with atrial fibrillation are treated with a blood thinner, it also increases the risk of major bleeding. And so this is a very sort of complicated situation where you don't want to expose the patient to the risk of stroke or MI, which is already high with AFib, even higher in AFib with cancer. But you do expose the patient to risk of bleeding, which is also already high in people with cancer. And risk prediction, in my opinion, in atrial fibrillation really needs to take cancer diagnosis into consideration, because the most classically used prediction systems for atrial fibrillation, which is the JADS2-VASc score, don't include active cancer as a predictor of outcomes. And as you see here, the incidence of ATE without cancer, if you look at baseline versus active cancer, it's 1.4% incidence. But if the JADS-VASc score is 0 or 1, but intermediate high risk is a 2.13% of incidence. And so cancer pushes people who are intermediate or low risk into the intermediate or high risk category. I can show you that in a better way in this graph. This is data from our institution looking at a large number of patients with different JADS-VASc scores. And as you can see here, a patient without cancer, which is in blue, with the score of 1, has a 1.66% risk of arterial events. But a cancer patient with a score of 1 has a 2.3 risk of arterial events, and that is very similar to a 2.5 score of 4 in a patient without cancer. So essentially, a score of 1 cancer patient behaves like a score of 4 non-cancer patient. And so we made the case in this article, and other people have as well, that maybe JADS-VASc needs to add an extra C for cancer, active cancer, because that actually changes the way risk can be predicted in atrial fibrillation. Of course, ischemic risk is heightened, but so is hemorrhagic risk, because cancer treatments can cause thrombocytopenia, can cause mucosal damage, already have a high baseline rate of bleeding. And so navigating sort of these events is challenging with DOACs and even with low molecular weight heparins. Are there non-anticoagulant ways to reduce the ischemic risk? Yes, there is a sort of device or approach called left atrial appendage occlusion, which is widely used, at least here in the United States. And we just 2 months ago, published this paper in Cardio-Oncology, looking at outcomes associated with this approach as compared to anticoagulation. Please keep in mind, this is not a randomized trial. This is just a real-world propensity-matched analysis. We had a couple thousand patients in this study. The primary outcome was major bleeding risk. And if you looked at just the control patients who didn't receive this procedure versus people who did receive the procedure, there's a significant reduction in major bleeding complications, but there were a very high number of major bleeding complications, regardless of whether they got the Watchman or not. The more interesting finding was that all-cause mortality at 3 months was significantly lower with the Watchman procedure, 3.6% compared to the non-Watchman procedure, 15%. Obviously, we can't say this is causality. It may be that people who were selected for Watchman were also people who were healthier and therefore could undergo a procedure. But this suggests that a non-anticoagulant way may be a good way to reduce the risk, at least to reduce the risk of bleeding and potentially benefit mortality in this setting. All right. Last portion of my talk is going to be on future directions. So can you prevent arterial events? And I want to point out sort of 2 possible approaches to this. I already showed you data that statins can be used to are associated with a reduced risk of arterial events in cancer patients. And we plan on studying this in a large multi-center trial that was recently funded by the NIH in the United States, looking at patients with a KS of 2 or higher, randomized to either a statin or to placebo, if you're not going to use DOAC. So if you consider these patients at high risk for bleeding, and therefore you're not going to use the DOAC, then we would enter the patient into the clinical trial and randomize to a statin versus a placebo and follow these patients for 12 months. And the hope is that we will reduce arterial events and venous events without increasing the risk of bleeding. So this study is just started to enrollment 4 weeks ago. A second approach is targeting factor 11. You already heard about it in a couple of the talks earlier, but very briefly, factor 11 is a way to optimize bleeding risk because targeting factor 11 suppresses the thrombosis pathway, but does not impact the hemostasis pathway. And there's a whole host of factor 11 inhibitors that are out there and currently in development. They include different classes of drugs, so aptamers, antibodies, peptides, small molecules, and a couple of these are currently being tested in the cancer population. We have data from one very large study of one of the small molecules, asundexian, given once daily compared to placebo in patients with acute stroke or high-risk TIA on antiplatelet therapy were randomized to getting asundexian or not, so 6,000 patients in each arm. This was just published in the New England earlier this year, showing that ischemic stroke was lower in the asundexian arm, 6.2% versus 8.4%, so cause-specific HR is 0.74, without increasing bleeding. This is the first proof of concept of efficacy and safety in a large randomized trial with asundexian, so very important for the field, and also very important for ischemic stroke prevention because no real drug since the antiplatelet therapy has been approved in this setting. So very exciting news from the factor 11 field. We do have one very large randomized trial already ongoing for prevention of VTE and arterial events. This is RoxyCat-1. Which takes patients with a Corona score of 2 or higher, randomizes them to either this Regeneron drug or placebo. This study is expected to open in 18 countries worldwide, and we should have data on that hopefully in the next couple of years. So just to sort of summarize, we've discussed a lot about arterial thromboembolism. It's an important clinical problem. Like venous thromboembolism, there's a high prevalence and incidence before the diagnosis, at the time of diagnosis, after diagnosis, and in association with newer anti-cancer drugs, including targeted drugs and immune checkpoint inhibitors. Arterial events are associated with worsened survival, recurrent ATE, but also paradoxically bleeding. Risk assessment approaches are improving. We have candidate biomarkers and candidate risk assessment tools. There is potential benefit of risk-adapted prophylaxis, and there's new therapeutic options, including possibly approval for asundexian for prevention of recurrent stroke. But there are major knowledge gaps remaining. We don't have a sort of a fully validated prospective risk assessment tool for ATE. We are not very good at predicting the risk of bleeding in this setting. And the role of factor 11 inhibitors is currently under an area of active study. So I'll stop here. Thank you again for this invitation, and I'm happy to either take questions now or during the roundtable. Thank you very much.
Thank you very much, Alok. Indeed, it's a new chapter with the same structure, it seems. So there are some questions, but it's better to discuss now. So I will do a question. Because as you know, we have the observation that has been confirmed in 2 independent cohorts that patients with aspirin and for previous acute coronary syndromes or arterial thrombosis that develop after some cancer, they have a higher risk of recidivant arterial thrombosis. And it seems paradoxically that the use of aspirin becomes a risk factor for recidivant arterial thrombosis. These are 2 other communications that we will present on Sunday with Nikita Lomatkin and also from our group. Do you have any idea or any comment about that?
Yeah, it's very interesting, and I'm aware of these data, and I think it's this type of data has been presented elsewhere as well. I think the concern is that, in some, I don't know sort of the full extent of your abstract, but in some cohorts, the use of aspirin may be a marker of other thrombotic past history. So these might be people who have a past history of acute coronary syndrome, past history of venous thrombosis, or some risk factor for thrombosis that their primary care physician put them on aspirin. And so in that way, the aspirin is acting as a surrogate for a thrombotic sort of phenotype, rather than a failure of antiplatelet therapy. I think the best way to resolve this is in large randomized trials. And I think I'm hoping that the asundexian trial, when it's sort of the subgroup analyses are done, there may be cancer patients in that study. And since it's such a large trial, we may get some more information about the benefit or not of aspirin in that setting as well.
Thank you very much. Any other, Professor Palomares?
Very good presentation, Mr. Corana. I have a question about you talking about, for example, OCEAN trial is focused only in one outcome, but in our patients, what we want is that they don't develop any arterial or VT event. Do you know if there is any initiative or any trial that have a composite outcome with or without statins and anticoagulants, or do you think that this will be feasible in the future?
Grigorios, I couldn't sort of fully hear. Can you repeat the question?
Sorry. You have been talking about analyzing the outcome. This is arterial outcome or a stroke, for example. Do you think that in the future, the mean point should be that the patient did not develop any outcomes, arterial or venous thrombosis, not only one of them, and probably with this approach, statin plus or less anticoagulant may prevent some of the outcomes? What do you think about it?
Yeah, I think that's a very reasonable approach. I think it's a shame that prior trials did not include arterial events. I think we were under the impression that arterial events were much less common than they actually are. And it's also true that in the past, cancer patient survival was much shorter. To develop arterial events, you need longer follow-up. I think both StatCat and some of the newer studies are including arterial events as a secondary endpoint and are following patients for a longer period of time because cancer patients, thankfully, are living longer. And I think that does change the equation somewhat.
I have the impression that we are moving in the cancer like the polychemotherapy. The antithrombotic drugs are becoming like these kind of anti-cancer agents. So many combinations will give better outcomes and new challenges.
Yeah, I think that's very true. In fact, in colorectal cancer, I'm a GI oncologist, and in colorectal cancer, we actually do sequencing of the tumor. And if they have a certain type of mutation, like a PIK3CA mutation, then we prescribe aspirin as a way to prevent cancer recurrence. And that's based on a New England paper that was published last year. So I think sort of this intersection of antiplatelet therapy with cancer biology is becoming much more, I think, better understood than it was previously.
Thank you very much, Alok. Okay. So we can move to the next part of the meeting, which is the workshop for the actual situation and in countries, among specialists and so on. And we did a survey, which was done, it was a very heavy survey, that questionnaire that we did, and was distributed to about 30 persons that constitute the scientific committee. And our ambition in the beginning was that these 30 persons will reflect, because they are among specialists and so on. And we did a survey, which was done, it was a very heavy survey, that questionnaire that we did, and was distributed to about 30 persons that constitute the scientific committee. And our ambition in the beginning was that these 30 persons will reflect, because they are specialists, country specialists, and key opinion leaders, and they know the field. And the ambition was that we could get an impression or a reflection of the reality, the perceptions, and the esperance of the national character of the national leaders. So this heavy questionnaire was answered by most of the members of the committee, and we are very thankful to everybody. And Marina Marchetti from Bergamo will present the first analysis. As you understand, in a questionnaire that took about 1 hour to fill, not too many data. She's part of the culpables for this huge questionnaire, because she increased about 20% what I did. So she will present the first data, and I think that in the near future, very near, we will have a full analysis. Mohammed, take it from the key.
So good afternoon, and it's not Marina. Okay. So my duty today will be to give back all the work that you did when answering to this Delphi survey. As anticipated, this survey was performed with technical. Okay, this survey was created with the aim of having two main answers. The first is to have on a base evidence made by expert opinion on what is the perception of the awareness and implementation of cancer-associated thrombosis worldwide. This is because the survey was provided to about 34 members of this of the committees of this workshop, and but we have back only 26 over the 34 members, but the answer were sufficient for having some statistic analysis of this of all the questions that, as Greg anticipated, were about 150 questions. So it was a very huge questionnaire, but the aim was to cover all the field, all the gaps, all the problems that a clinician and a patient engage during what is this problem of the cancer-associated thrombosis. So how we analyze the data? The data are very simple questions. So we provide you like means, standard deviation, some correlation analysis have been performed. But what is very important, and as Greg said, that this is a national expert design of this questionnaire. So the evidence of the answer were provided by the most expert in the field from each of the country. And also it's very important that for this questionnaire, for this survey, they will use all this approach based on the 4 pillars of to have a very I can say evidence-based results. So these are called the CFRI for identify the determinants, the Proctor outcomes taxonomy, the REAIM, and the ERIC strategy matching. So these are all very important framework that are very useful for identification of barriers or what else, and provide also some help to identify how to proceed in the after the identification of a problem, how to proceed out of the problem and having
a very important, sorry, I did something wrong, feedback. So here are the 4 pillars explained, just to have some ideas of what is this evidence-based approach. So the CFIR 2.0 is a consolidated framework for implementation research. So it's an organized framework. So it identifies the determinants, so the specific barriers and facilitators across 5 key domains that you see in your, for the people that answer to the questionnaire, among the questionnaire. Then the Proctor Outcomes Taxonomy is a system that clearly defines and measures the actual success of the implementation. So it is based on 8 core variables: accessibility, adoption, appropriateness, feasibility, fidelity, cost, penetration, and sustainability. Then the REAIM is another framework that used to track the real-world impact and public health success of a program. So measure 5 dimensions: who participates, which, does it work, effectiveness, do clinics, schools take it on, adoption, is it delivered correctly, implementation and maintenance. So it is sustained long term. That is very important item. Then there is the ERIC strategy matching, that is an expert recommendation for implementing change, ERIC, and is a compiled taxonomy of 33 specific implementation strategy. So all these were used, all these framework to perform our questionnaire. So who responded? So we have 26 experts that answered to the questionnaire, and 42% were hematologists, followed by 90% of cardiologists. Then we have vascular medicine, and 8% of medical oncologists. And if we want to divide this expert by practice settings, we have that 73% work in a university academic context, while 90% in a private practice. Then we have regional hospital and other. First, this is awareness and implementation. So 2.9 is the score that was achieved about perceived guideline awareness among clinicians. So 1 is very low awareness, and 5 means that is a full awareness. So we this is the score that we obtain, so 2.9 over 5, but about the perceived guideline implementation, we have a lower score of 2.7. So there is that awareness, this is the title of the slides, awareness at spaces implementation. Then we perform also a correlation between awareness implementation towards individual, at an individual country level, and we found that there were more higher correlation at the country level. So it is not only a problem of knowledge, but also is it very important the context where the expert works. So what were the top rated barriers that were identified across all categories? So we are in this graph, we have an analytical detail about the most severe specific barriers. So all that achieve a point higher than 4, so from 4 to 5. All these barriers were identified as something that block the implementation of the guidelines. And we have 2 main domains. So there is a domain regarding the structure and the infrastructure. I don't know how to say, but for example, one of the most important items is that there is no electronic medical record integrated for VTA risk assessment. So this is one of the first barrier for the implementation of the guideline, but also the lack of an audit of a mechanism of quality implementation. So I do, but I have also to measure what I do. If there is also something that I can improve during my practice. Then we have also something about personnel. So insufficient fellowship training, 4.19, as well as insufficient allied health support. So this is another important, how do you say, barrier for our guideline implementation. And then there is also the problem of the knowledge. So lack of knowledge on risk tools, and as well as lack of knowledge of other specialties. So also from other people that of the team that is very important for the implementation of our guidelines. And this is another very important result of this questionnaire. It is about the psychological impact of the cut on our patient. So there were 7 psychological items, and these items were rated more than 3.5 over 5 points, that is the maximum. And the highest rated psychological concern, as you can see, were patient concerns initiating apixaban, rivaroxaban, bleeding risk, the absence of antidote, 3.8, the impact of administration mode, so the injection versus oral on quality of life, 3.8. Then we have the distress. Informing patient VTE is a fatal cancer complication, 3.7, and clinician own distress, delivering life-threatening risk information, 3.5. But another important aspect that was evidenced by the questionnaire is that only 7.7% of the expert know that there is a systematic assessment of the psychological impact of CAT, and that use also for this assessment a validated tool. So what is very important is a validated tool for this for the assessment of this psychological impact. And but the agreement is very high, 3.5 agreement that this psychological impact, the psychological aspect should be standardized in protein pathways. And the rate of agreement on standardization at 4 or 5 points is about 35%. Then about all the Delphi consensus, so 75 items, statements, the agreement was very high, 4.28. And also the agreement about the support for an ISTH endorsement international initiative. But 2 items, 2 statements remained contested. And these 2 most contested statements are: the first, apixaban 2.5 milligram as a universal secondary prevention dose beyond 6 months, and the second, routine Caprin score used for all surgical cancer patients. So these 2 items probably will be discussed. Then there is also the evidence for an awareness gap when we compare guideline awareness in the university academic setting as compared to the private practice. As you can see, 3.2 versus 2. And this difference is statistical important, but what is important is that the awareness, if you are aware on this practice, normally the rate of clinician that then adopt and implement the guidelines is more the same. So it's here is a problem of diffusion of there is a dissemination gap between the academic towards the private practice. And then
in this slide, you can see that if there is no real agreement between the awareness, the implementation, and the barrier burden, so the economic burden. So in those countries in which the awareness is present, the capacity of the implementation of the guidelines is lower as compared to countries in high income. And this is related to the problem of the economical problem. So then we have another important results. So where are the barriers of fundamental? And the primary institutional structure is the primary gap. So what does it mean, institutional structure? Is the absence of protocols, the integration of electronic medical records of the score, the coordination of the team. And it's not the problem of the guidelines, it's more a problem of having all the organization for implementing these guidelines. And here are the proctor outcomes. So the guidelines are well accepted, are appropriate. So you see the higher score, but the adoption and implementation are the lower score. So it means that there is a problem in the adopting and these guidelines, and also to diffuse them. And this, so what we need to fill this gap will be part of the discussion today. So these are the 8 discussion points. So closing the EMR digital integration gap, institution protocols, the coordination of the team, the audit, the clinical knowledge and confidence gap, the 2 contested Delphi statements, Rivaroxman, Ricci clinician outside academic centers, so between the academic and the non-academic center, the physiological burden of patient and clinician, the political and policy engagement, and the addressing economic development gradient. So I think I can stop here. Here the last
analysis. So since Marina stopped the question of the institutional stakeholders, governments, and so on, I would like to give now we have a round of some representatives of countries that will transfer live their perception and the point of view. So I will start with Dr. Agathangelu, who is the president of the Medical Association of Cyprus, and they are working closely with the Ministry of Health of Cyprus, which, in contrast to the Greek Ministry of Health, has a very precise and a very clear line for the management of public health and venous thromboembolism. So, Petro, we can hear you to transfer our Cyprus experience and the perspective.
Thank you. Thank you for the kind invitation. I congratulate you for the initiative. Cyprus, indeed, as you have mentioned, Grigorios, is quite sensitive on how we can convert policies into clinical practice. And as the previous speaker has quite clearly outlined, there are a couple of things to be improved in order to meet the gaps. Indeed, the Ministry of Health in Cyprus is quite concerned how we can implement, especially an issue that has been ignored for many years in the multidisciplinary approach in managing patients with cancer, and especially when we all realize that one of the most common causes of death in cancer is the cancer-related thrombosis and its complications. Definitely, we are aware of some of the unmet needs and we're trying to improve. And I'm pretty sure that if there is a universal principle of how we convert um, guidelines, European model guidelines, into a clinical practice, that will help a lot. Indeed, the electronic medical records of great importance. In Cyprus, we have newly implemented a healthcare system, which now is being matured. We move from infantile stage to a more mature level that we can collect data in a better way, and with the help of the ministry and at the institutional level, including academic environment, that will really assist in our process to bring the patient's awareness, doctors' awareness, different disciplines bringing together from primary care physicians to specialties like cardiology, like internal medicine, specialties that will need in order to recruit guidelines that will be well understood and fully implemented for patients' safety and patients' participation as well. The shared decision-making process is of crucial importance in this kind of approach, and we are at your disposal as country, as institution, and of course, with the help of the ministry to support your initiative. And I congratulate you once again for what you've been isolating as an importance and prioritize this issue of cancer-related thrombosis.
So, Dr. Rathagelo, thank you very much. It seems that you have incorporated the deep philosophy of this project of cancer-associated thrombosis. So what we are expecting from you as a political factor now, and not as a scientist in medicine, is that in the frame of the ICTHIC, in the frame of the Centre de Recherche Saint-Antoine or the ETA, we will have because we need political support, and I know that we can trust Cyprus.
Rest assured, we will be supporting in every aspect, in every stage of your efforts.
Thank you very much. So
thank you.
Thank you very much for the intervention.
Thank you.
We will keep in touch. Thank you. And
yes.
enjoy the sea and the sun.
Thank you.
And
all
the
best to everybody. Yes.
The Sivania also.
Thank you. All right. All the quite best for you.
Thank you. So now I will invite Professor Nikita Lomakin from Moscow, who will say the experience of a big country, the population, and it's.
So, dear colleagues, first of all, I want to say it's a great pleasure for me to be here, and thank you to Grigorios for this kind invitation. So, and I want to show you some slides. I think it will take not less than a couple of minutes. So, I'll show you the last one because last one is here. So, because it's strongly related to the topic we discussed today and the crucial role of the workshop we're doing today. So, these Russian letters you see on the left-hand side of the slide. This is the guidelines. First of all, they are pretty old. So the second issue is that it was released by Russian Cancer Society, and there is no in the list of authors. There is no guys from the Hematology Society, from Cardiology Society. This is on the Cancer Society. So this is practical guidelines of prevention and treatment of thromboembolic complications of cancer patients. So what we know from these guidelines, so among Russian population, there are about 20% of patients who experience different kind of thrombotic events during their lifetime. So, and at biopsy, when they die due to cancer, we find about 50% of patients at autopsy, we find different kind of thrombotic events. And the most important thing that there is zero percent of evidence in these guidelines regarding how we could manage patients with arterial cancer associated thrombosis. So there's no evidence, there's no incidence. I mean, how many patients with arterial thrombosis have in our country? So, and in this regard, I would highly appreciate Professor Gerotziafas that he invited and involved us, I mean, our Moscow scientific team in his very important work. And I want to invite you to our Sunday session. So we will present some data which comes from Russia, but it was done under supervision of Professor Gerotziafas regarding the arterial cancer associated thrombosis. So, and taking into account that there's no direct flights between Moscow and European countries today, so I want to show you some slides what we're doing today in the field of thrombosis and antithrombotic therapy and education in our country. So we have Russian Anti-Thrombotic Forum. This is sort of scientific society which was established more than 14 years ago. And we started from the regional workshops. And by this date, we performed more than 200 workshops in 45 cities with more than 30,000 attendees. So the next thing we started to think what could be done from our side to our healthcare practitioners. So we released sort of guidebook of antithrombotic therapy in scores and algorithms. So by this date, we have 3 editions, and we release it free of charge for all our doctors all over the country. So, and more than 50,000 books were released and spread throughout our country. So during the COVID time, we established the webinar studio in our hospital, in Central Clinical Hospital. So, and we already performed more than 150 different webinars with more than 20,000 attendees. So, and this is like top of the iceberg of our society. So this is the annual Congress, which is dedicated to the World Thrombosis Day. The name is Day Against Thrombosis in Russia. So, and this is the picture which comes from the last Congress, which was held in Moscow in October 25. So, and as you can see here, was a great pleasure for us to host Professor Grigorios Gerotziafas, Professor Elalami, and Professor Tsihan I in our country. And at the center of the slide is a Minister of Health. So he presented together with the Vice President of Russian Academy of Science, he presented the diploma of foreign member of Russian Academy of Science to Grigorios and to Ismail. It was a great pleasure. And you see a person at the middle, at the center of the slide. So this is the most distinguished expert in the field of thrombosis in our country, and it's a great pleasure to be here today with Alexander Makatsaria and to present our country during this workshop. So also this is the national continuous medical education learning platform, which we established a couple of years ago. The name is Thrombosis and Antithrombotic Therapy in Real Life Practice for different kind of specialties in our country. It's also free of charge. So, and this is some kind of the social activities. On the left-hand side, this is a leaflet, and you see this bullfinch. It's a bird. So we made some kind of animated movie related to the frequent flyers prophylaxis during the flight. So we spread this information every October on board of the aircrafts in our country and in our regional and Moscow airports. So and this is the most exciting thing we done last year. So this is the tallest building in our country. This is the Ostankin TV tower in Moscow. So, and we illuminated this tower during the World Thrombosis Day by the lights of World Thrombosis Day, World Thrombosis movement. So, and that's my last slide. I want to invite you to our forthcoming meeting. That will be 4th National Congress Day Against Thrombosis in Russia. It will be a great pleasure to see you and to host you. Thank you so much.
Thank you very much, Professor Lomaki. Now we move to the other side of the Atlantic. Professor Alfonso Tafur from Chicago. It's time to wake up. Because it's the jet lag. So, from the University of Chicago, and I think that it's here.
Was online thing. It was this week. Was a link. No. It's a link to send you.
It's a link.
I send you a link in WhatsApp.
Technical issues.
Yeah.
Oh, we can.
Just looking at WhatsApp. It will be very soon, so you can't.
Just once.
Please online. I can just.
You can start speaking and then.
Yeah. So thank you, Grigorios. Basically, what Grigorios asked me is to say hello about some other project that we have together. In trying to bridge this problem of the static score versus transportability. Let me see if I can actually get to those slide sets here. Sorry. I'm seeing
the slides here, but how I can.
Oh, then let's connect it one hour. Anyway, let me just talk. I mean, we'll do that. So the concept that we're doing is we created a platform for BornMD, and the idea is that we have had for decades, and Joe Caprini actually we spoke about that for quite a while. But we spoke with Joe Caprini for quite a while on this idea of what can be going next. So we have all of these concepts that you had, my goodness, 50 years ago, and this scoring system, and then the frustration that as the patient evolves, he's going to change multiple times, even in the hospital. So the typical story, Joe actually comments on that patient that he's very passionate about these legal scores. The patient who died after was diagnosed with a pneumonia, after having had surgery, etc. So the score changed, and they were accusing him in court that his score didn't work. Because at the first day, the score was X, and then by the time that she actually died, the score was different. Well, no, but you are missing the point. The application of these scores is supposed to be dynamic as well, right? So how do we move from the static score to the dynamic? And then the concept is even later, how do we move from that to actually testing in silico? What is the application of the multiple opportunities that we have for therapy? So on that concept, again, we created this platform called BornMD, and we have already we sent a first abstract to American Heart Association. We're working with Grigorios on utilizing the cancer-associated thrombosis information as well. It uses the concept of a digital twin. So let me expand on what a digital twin may be. I already have a patient, a live patient, in which we put into this platform his whole genome, 100% of his genome, which quite honestly, I would argue is not that expensive to do anymore. $250, and his whole gene is inside. We absorb all the medical records of multiple institutions into that. I can access 24/7 his wearables. So he's a tech guy, right? So he uses a lot of wearables, and all of those are in there. Microbiome. And with that, we're training the machine to give him much more educated information about not a single moment in time, but about his day-to-day. So he's going to be a different person when he's active, when he's not, when he's having variations in blood pressure, and can actually capture that literally 24/7. So that gives me the idea of a digital twin. what can I do extra for that? And that's when it gets actually exciting, and it's the analysis that we're doing right now. Let's say that I have to give Professor Palomares a fake euro. And you say, well, this thing is fake, throw it away. But I can get very good at it. So we have GAN mechanisms, so generalized adversarial networks. So I have two trained AI systems. And one of them is trying to trick you. The other one is trying to tell me you're not good enough on tricking me. We do that thousands of times. And then finally, I have patients that I don't longer need the static statistics of yesterday into just using AI for what it is today on trying to do extra matching, right? Because at the end, we only have so many thousand patients that we can ultra match for having some very specifics. I can generate that specific patient that you have today and ask the question, if I have 10,000 of this individual that needs a surgery, that may or may not need a filter, that had an incidental PE, and I throw X, Y, or Z mechanism based on the data that we have already collected, what's the odds of having a better outcome or a bad outcome? I would argue we already try to do that today, but we're doing with our own minds. And I would argue that the technology that we have today is getting underutilized unless we go from AI to the next section, which is digital twin and digital twin counterfactual. So that's really what I wanted to share. And obviously, I mean, those slides like those slides that actually we can share them together as well. Yeah, sure. I can fly through this, which actually relates a lot to what I just mentioned. I don't have the actual presented data. These data are not published yet, but it's been submitted. On the transportability issue, actually, we just finished a paper on the RIETE information. It's on 70,000 individuals in RIETE, and we tested the portability of VTE Predict into patients with cancer with readjustments, testing the first part of this digital twin scenario. I mentioned this, I'll fly through it. So here, basically going from the historical clinical intuition, which we do better than that already. We do risk scores, we do better than that already. We do this, and then the selling point that I want to consider, which is already starting to percolate in some areas of cardiology, is can we utilize the digital twin to tell me the counterfactual? At least with an N of 1, I'm already doing that. I'm suggesting that with the 3 major databases that we have acquired in the last few months, we're going to be able to start testing this more in this scenario of cancer thrombosis with Grigorios. I'm looking forward to your help. Actually, he already saw some preliminary information on how I'll tell the story. Basically, we put Born MD to the fire, and then we shared some information on the database that he actually shared with us. And I literally asked it. So my colleague, my partner, the tech guy, like sci-fi movie, he just presses a button and he asked me, okay, I throw out a question. I devised a PICO question. So amongst patients with cancer and a history of risk of thrombosis, what is the potential prediction score of an arterial event? And give me that after several bootstrapping analysis based on the preliminary data that we have here, non-analyzed yet, and give me a potential score. It replicated almost identical the data that you have been working on for several months, and it did so in 2 minutes. The same way it actually replicated some of the data that I'm working with Manuel Monreal on exactly the same question. So I think the digital twin idea is going to take me from the idea of this static to dynamic, but even better, the idea that I can now test in silico the question of what do I do with my patient to date when this patient cannot be randomized. Because some purists, and I used to be a purist, some purists will tell me we need to wait for the randomized trial on this specific question. I'm sorry, that's not going to happen. Thank you.
Thank you, Professor Tafur. I think that you confirmed an American book that was very, very popular in the years of 2010 that said that PowerPoint killed teaching. And doing this presentation, the first part without PowerPoint means that you are a good teacher first. Second, you are just saying interesting futuristic things that respond to the needs that we have just developed. And this is very, very important. It's a question.
So about digital twins, do you know how many patients, how many variables do you need to implement these digital twins? Because This is the problem, no? I don't know, if with 100 patients, you can obtain 1 million of digital twin patients?
We can actually, we tested the platform for multiple types of counterfactuals. So there's counterfactuals that are famous to be very labor intensive. And that was one of the fears. So we're going to have really the computational power to actually do that what we're promising. And well, the answer was yes. So we were able to already do diffusion models comparators. That is very labor intensive. You're measuring how many time hours of the graphic designer machine that you're using. It lasts less than 0.3 seconds. So in real time, we actually can analyze at that level databases of over 20,000 patients already. As far as how much information the machine is carrying for my N1 patient, we literally have his whole genome, and we're playing with that on questions on demand.
The problem is the quality of the data.
The quality of the data and the transportability, sure.
Okay.
So how am I fixing the quality of the data? We're not feeding the machine with, so this is proprietary AI. This is not ChatGPT or cloud. This is a in-house AI, first of all. It's not allowed to actually go find information in Dr. Google. And we have fed it specifically with parameters of which data to inform and which multiple sections of cross-checking what it's actually doing. So we've injected some safety parameters on that because I also very distrustful on hallucinations, of course. So the machine was really built around that. As far as other information that is actually carrying, as I was mentioning, so it's already capturing and has the capacity of including wearable microbiome every 6 months and absorbing the clinical data. We partner with a company so that all EPIC data, that's our main healthcare system in EHR in all the United States, but it's able to capture not only that, but other parameters to just put it in information. What's going to be the problem when we actually try to send it to public and we try to train in other people? That is a challenge. What we're thinking is for launching, and that's more futuristic, is that those layers of data have to come with a gradient of hierarchical acceptance. So it's not the same to actually put a data point where the patient tells me, let's say, a questionnaire. I cannot think that is untruthful, but then it have to be cross-checked and signed off by the primary care before it gets accepted for full analysis. So we're thinking about those parameters when it actually goes to distributability. Then the transportability, I think, is one of the more exciting things because one of the things that we found on these recent manuscript we are building with Riete, for instance, the scores that have been built in randomized control data, when we compare it to Riete, they don't have transportability. Not because the score is wrong, but because by definition, we excluded a lot of people that are real people. So if nothing else, that is applicable immediately with not that much computational power.
And if you allow me, there is a limitation with the scores because all the scores that we use today, they were done in the years of 2000. And the Corona score was done with a database that was set up in the years of at the end of the 20th century. And we know that in order to do a new score, we need to spend money, and we don't have money. And we need about at least 7 years from today if we decide to do a new score to cover the questions that we have. This means that in 10 years, the medicine will change. So we will be always behind out here. And this is the great advantage of these tools.
Yeah, and you can do an in silico trial on demand for the questions that we have. To me, that's exciting.
The question that Vacasa is Dr. Vacasa Kempaya is from Loyola.
Oh, yeah.
So my question is how cost effective to assemble microbiome data, transcriptomics, genomics, into clinical parameters, but the biomarker, is it going to be cost effective to
So that's a great question. You know, when I partner with the person that is helping me build this idea, that was precisely my question. So a lot of you know, I mean, I had a heart attack when I was 44. I actually figured out my own diagnosis. I figured out I have some predisposition that was not discovered before. And I figured out in the United States, I reach a lot of privilege to actually go all the way deep into my diagnosis. Okay, so I called a friend, May, okay, do this and that. So he literally, they did things that are not normal care. So I shared that with him. And then the idea was we can popularize this because right now we're person dependent. I can only see 25, 20 some patients a day, and then I don't want to see go home, right? So with this machine, you can have the persona of the physician thrown out to millions at the same time on your information. So that is actually what we're building. We're not building just the digital twin. We're building the persona that comes around. My wish is to have the kind of medicine my grandpa used to practice, the one in which you still listen to the patient, but with the technology of today in a single platform. To me, that is actually popularizing. Is it cost effective? We are thinking tiers. Again, I don't think that your genome for $250 is expensive. It's a once in a lifetime. We're not planning to CRISP you, right? So if that is what it costs to improve that kind of granularity of information into the platform, I think it will be promising.
Great to meet you, Rohit Chitale from Mayo Clinic. We just flew in this morning. So a few questions. You said those are proprietary models that you're using, or?
So that's public technology, all of that. What is proprietary is the module that we're actually using. So VAST, we're calling it, because we have introduced a lot of safety barriers to it. And that's of course, we're still testing through it. We are doing the first few papers, and then we're starting to launch it.
I'm thinking a little bit about like comparison of what you have in your models to maybe some of the ones that are over from ChatGPT and some of the others. I'm just wondering, that's kind of one question. Number two is, how do you feel about is there a validation that you can do here? It's really hard to do this, I understand, but I always think about validation here.
Absolutely. So we do want a lot of channels in that. So I train them. So basically, one of the databases that we're using, I did with my mentor, Robert Marbains, we're trying to use that for having multiple data to retest that. I think the validation segment that we are planning, so there's two tiers, one for the digital twin per se, so that's really cross-referencing to multiple databases, what we have found. Then there's public databases that include some additional genomics, like UKB, for instance, so we can actually put transfer learning into understanding, can actually transform this into putting extra layers. That's for the digital twin per se. For the counterfactuals, yeah, I don't have a good way to tell you I'm going to validate that, except that on Riete, and this is futuristic, but what we discussed with Manuel Monreal was to consider a staggered, a stepwise clusters trial in which we give the engine, if you may, to one center at a time, and then ask them, well, use this and see what you actually think. There's no forcing, you're just chatting with it. Of course, it's going to influence your care. And then because it's going to be included in one center at a time, in a limited amount of time, we would hope to see, okay, is this making a difference or not? That would be the ultimate validation to me. That's going to take a bit. Yeah. Hi.
It's okay.
Okay. My question is similar to this point about validation, because I wonder whether if you have thought about how you validate that for other populations, because we think about SNPs varies according to populations, as well as microbiomes and so on. So it's just this question.
Yeah, so I'll give you two answers on that. I'm very sensitive to it because one of the genes they found on me, I'm Hispanic. So it was, oh my goodness, you have a new gene and this is never described before. Well, yeah, how many databases do you have of Hispanics? So first of all, at the end, it wasn't functional anyway. The validation that we are thinking is once we start expanding other types of information like acquisition, then to have cross-validation of that population that is being acquired. So for instance, let's say that we actually are able to launch in the communities that we already know that the data is originated from. But let's say I'm good friends of Eduardo Machotti, and then basically we already pitched the idea of Eduardo, can you actually consider having some testing pools over here? Those patients include their information once you actually have a flywheel effect, we are able to revalidate our findings and recalibrate. That is the transportability. So we that name that I give in transportability is precisely what we tested on that AHA abstract that we did already, is the idea of having a score and then recalibrating to the true prevalence of disease somewhere else. So then your created score is not useless, it wasn't lying, it just has to be recalibrated to the new denominator. Perfect.
Well, just a general consideration. Okay. Clearly, science is running much faster than clinical practice. As we can see today, the implementation of guidelines or the first, level of standardization of some criteria to establish whether or not to give prophylaxis to some people and not to other people are relatively simple, but there are a number of barriers in implementing that. Maybe sometimes even easy, could be, I don't know, the implementation of an electronic system or stuff like that. It's relatively easy, but it's not done in the majority of hospitals. You think that your approach can help this diffusion, education, and implementation of what we know from science?
How do we
or we have to find the magic the magic item that is really simple and can be applied every time, no patients and sorry.
So another way of reading, thank you for the question, of reading that, is it getting overcomplicated so it's going to be impossible to apply? When I think implementation, I got honestly frustrated, quasi-suicidal frustrated, when I had been playing with implementation of institution for the longest time, to the point that I said, okay, forget about it, I'm going to do an MBA to understand implementation and then have somebody who knows implementation tell me. So that's the business people, regretfully. I didn't understand any of this in school. And the best acronym that I thought is brain, hands, and heart. So we have to combine the three together. And for the longest time with Joe, we had been fighting the institution to give them brains. We were vomiting data on top of everyone, and nothing happened. Then we figured out, let's give him hands. So we partnered with the institution. We created and embedded in the EMR automation for a lot of things. So I'm happy to say, I mean, every UIM patient, every lung cancer patient gets a screen immediately in the institution and before chemotherapy. And it's based on the Corona, but with some added variables. And then I don't have to vote on it. They automatically get put almost always in a pixel, quite honestly. For the same thing for the E-Caprini, we name it. Joe doesn't like it. I don't know if he's logged on now, but I don't love it, but it's what was able to be implemented. So it's not perfect, but the E-Caprini gets measured every 5 minutes in the computer real time, and it flags you with a red flag if you're not giving prophylaxis. Fine, it's not perfect, it's not a true Caprini. I don't care. It's putting a notch, and we actually were able to demonstrate decreased rates of thrombosis in over 60,000 patients in my corporation. So that is the hands part. The heart is harder. And what I'm hoping with this is actually not a physician tool. I think this is going to be a patient tool for the patient to own their health. And I heard you multiple times asking, we need to teach the patients. Yeah, but I want them to understand their health from a better educated way, not from Dr. Google anymore.
I think there are other questions now, not. But there are suggestions from other ideas. So I think we have discussed quite a bit about how to implement prophylaxis nowadays, and also with some perspective for better doing in the future. So, what do you think?
About the future? So about the future, I think what I imagine is that I am here, and the general practitioner who is in the Ikaria Island, in the middle of the Aegean Sea nearby Turkey, completely abandoned by the state. will be able to treat a patient with myeloma and venous thromboembolism, or even without venous thromboembolism, give the prophylaxis, and has the specialized and the expertized opinion from the group which is here, with a connection with e-health, telemedicine, and electronic decision support tools. And that this general practitioner in Icari Island will be capable to be updated and supported and feel that he is supported. So this is it. And I think that this is not the far away future. And also it's something that we discuss with Corinne very frequently because we are doing our consultation together door to door, is that what we are doing now here in Paris with the dogs, for the big majority of the patients, we are just prescribing, no? Because the patients are safe, they are in a good situation. But when they hear the bleeding in very village, neither I or Corinne will be available to give the information. And this is the real problem.
You want to comment on that?
On the comment on how to provide better access, well, I'm not familiar enough with your system. That was a question, and somebody asked me the other day. There was this applicant to pathology, and they asked her, "How familiar are you with the massive transfusion protocols?" And she's a just graduate, and she was going to take a place in Illinois in the middle of nowhere, several hours away from Chicago. And I'm like, well, I haven't done many of those, and that's fine. Can you ask someone? Can you actually go ahead and have a system that agrees and is easier to transport, that have that brain part embedded into our day-to-day? So things that we did with Joe, we tested some information on the nudging to try to just guide practice. But honestly, the electronic decision report has been proven and proven again that it's more valid than education itself. Regretfully, we can educate ourselves or other people 1,000 times, but it's noble, doesn't work. You just need to embed in the system and automate it.
So I will invite my collaborator and co-worker and friend Pedro Lascazas, who is working something like this electronic decision support tool, and we did it in the trauma-induced bleeding. And we choose the trauma-induced bleeding because this is the most difficult field in our domain, because bleeding is now it's aggravates and demands this repeating approach that Alfonso described. So he could describe us how he worked with a company. They are doing military AI. So they are developing, the platform that they command the drones. So, and how this technology has been transformed to the medicine. You will not say the secret?
No.
Okay.
Well, we're recently trying to deliver care in remote places and where we cannot deliver what we know. So somehow what Professor was talking about experiments in the village and things like this. So we started a prototype with AI, a kind of machine learning, and trauma and bleeding. We are assessing through some questionnaires, some scores, and we are doing a multivariate analysis, incorporating data like hemogram, gasometry, and the road in order to the machine deliver what we should offer the patient, why they're not doctors around. So it's used for the primary setting of rescue and things like this. So red blood transfusion, a plasma transfusion, tranexamic acid. So the machine learning is trying to develop giving a better care until the doctor is available. And also it's already integrated that it can already contact the center. So the patient goes to the center that has the most ability to take care of the patient, like it's a primary care or secondary care. It needs a neurosurgeon, it needs ICU, so it contacts the centers in order to organize how to manage the patient, where the patient can stay. And we're developing, this was our first prototype, the trauma. We're already working with two more. One of them would be cancer-associated thrombosis and how to manage it in remote setting on where we hematologists cannot be present to take care of this. So that is our goal. One of the goals now here in the lab to deliver care using machine learning and putting our knowledge in where we cannot be.
So another thing that we can say is that with this technology, you can answer 10 questions, and the algorithm will do what we call personalized medicine, and it gives now the recommended strategy for this patient now, and also you have the possibility to do the follow-up, the dynamic, and the pharma-induced bleeding is the most demanding. This is number one. Number two is the geolocalization. You can identify where the patient is, which are the local conditions, and act accordingly. So this is a huge chapter. And I will give you just one number that I wrote yesterday. 30 trillions will be the investment in e-health in the Western United States, Europe, in the next 10 years. And the increase is about 30%, correct? So it's about 30% in the growth from now. I don't know if this is speculation or something like the other thing. The question is now that there will be a lot of money that will be injected in the e-health. So it's our duty, from my point of view, to do it correctly and not leave the others to speculations.
I think that the future is clearly with the systems, and the world is changing, and we have to redesign new models to work and to think of health and care, but also of work and all aspects of our life, probably, because we have an aging population with less people, with the lower nativity, and so there is everything that has to be redesigned with this data that we have now. So the world is really changing, and probably this is true. Every 100 years it happens that there is a big change, and probably we have to do that and be prepared to do that. If there are, okay, you want to comment?
Yeah.
Okay.
I'm Rohit Chitali from Mayo Clinic.
There is a big change, and probably we have to do that and be prepared to do that. If there are, okay, you want to comment?
Yeah.
Okay.
I'm Rohit Chitali from Mayo Clinic, and I'm just joined the team recently. And so one of the things that excites me about this work is you have these silos of excellence, Dr. Before you're talking about the models and really leveraging a lot of this high resolution data. But these silos of excellence are wonderful, but how are we integrating these silos? Like, how are we actually using these together for pre-hospital medicine, for trauma care? I'm an infectious disease guy, so this is not my area, but I'm learning. But I think that the integration is really the key, right? So like I worked at DARPA, Defense Advanced Research Projects Agency in the Pentagon, worked on the COVID vaccine several years ago. And there's a lot of really deep innovation going on, new models, Claude and Anthropic, but who's knitting this stuff together? And so the idea here is that if like 20% is innovation, fine, but the real key here is the integration of all these different digital health, e-health, AI, these kinds of things. So that's what excites me about this.
Yeah. Okay.
Professor Caprini is online, no? Oh, there he is. So.
Good morning. Good afternoon, actually. Yeah.
Really?
Sorry, I was double booked this morning. I'm a communion minister, and I had to serve communion to the nursing home, so that's why I wasn't here. And thank goodness for Alfonso for presenting my lecture. And are we discussing now?
Yeah.
Yes.
Can I make a couple?
The question is how we can do the E-Caprini score and integrate the E-Caprini score in the decision electronic decision support tools, because we had a debate in the survey that we did. We asked our colleagues if it is necessary or a good idea to do Caprini score to every patient with cancer, any kind of cancer, who is going to be operated for any kind of operation, cancer operation. And the results are very dichotomic. There is no consensus. Somebody, the half says that, yes, we must do it, and the other says, no, we must keep Caprini outside. So, I am a little bit provocative, but this is the truth.
I would like to have some comments regarding that. And you all heard my lecture, and in my lecture, it was very clear that the Caprini score per se it has some limitations in the cancer patients. But the one thing that I think people miss is that every cancer patient should have complete risk assessment. Forget Caprini. You don't like Caprini, don't use Caprini. But what is Caprini? Caprini is 40 factors associated with venous thromboembolism. So failure to ask these 40 questions about venous thromboembolism is failing to serve the patient. And remember that risk assessment, we don't treat risk assessment, we treat patients. So risk assessment is just the beginning. You have a patient who's Latin and has thalassemia. You have a patient who's Black and has a sickle cell. You're not going to include that in the algorithm? Give me a break. So the answer to that question is, when you send out the survey should say, do we need to ask all the available questions that have been validated in the literature by whatever means to each and every cancer patient? And I would say, if you don't say yes, you're not treating your cancer patient properly.
So I will continue to be provocative, Professor Caprini, although I know the field and the answer. Yeah. There are new scores now with the AI producing data and the data mining and so on. There are new scores that they are putting in question the validity of the Caprini score, because we have retrospective analysis which are coming from the 4 signs of the horizon. So what is your position? Do you need new scores, or we need to incorporate the existing in these electronic decision support tools that accumulate prospectively data to improve the existing score? We do. Is it necessary to do an inundation of our colleagues with a new scores, or we improve what exists?
The enemy of good is better. And my view on this is that we need to take the existing score and we need to add those factors which have been shown in the literature to be associated with venous thromboembolism into the existing score platform. Sleep apnea, diabetes requiring insulin, thalassemia, sickle cell disease, a variety of other factors that have been shown in the literature, but not officially picked up by the guidelines, because remember, we don't treat guidelines, we treat patients. Now, having said that, and Alfonso and I have a little discussion about that, it is my firm belief that the reason that the incidence of venous thromboembolism is not decreasing, but rather increasing, is the fact that there is failure of implementation of evidence-based pathways consistently. And that needs to be done using nudges. The Boston University has published 18 papers where they mandated the score. And although the doctors had an opt-out, the nudge was that the success of the program caused the other doctors to buy in. And so over a 12 or 13 year period, they were able to consistently keep the venous thromboembolism risk and fatal deaths very low. But failure to implement what we already know, it's not that we need more and more. Failure to implement what we already know is a real problem. And there's 2 more comments about this that I really am frustrated about. Retrospective analysis is flawed. You don't know who asked the questions or if they asked all the questions. And there was a recent database from the VA of 1,200,000 patients, and they used an administrative database. And we know an administrative database is for global health issues, for finance, billing, but it's not suited to identify risk assessment. In that 1,200,000 patients, there was no captured family history of thrombosis. There's 2 excellent studies, one in 2012 and one in 2024, totaling altogether, the first study was 183,000 patients, showing that first, second, and third degree relatives with a history of venous thromboembolism impacted the patient without a history. And then in 2024, a follow-up study with 750,000 individuals in the data set showed that there are 8 levels of risk associated with a family history of thrombosis. Totally ignored by that database. My own institution doesn't collect that information. And these are some of the things that need to be done. Prospective analysis. Any paper that you read talking about the number of risk factors, in my opinion, is flawed, because unless you have the power of each risk factor and the number, you have no idea. You have a less precise indication of the incidence of venous thrombosis. For example, a young woman who has 3 risk factors, hormones, BMI, and age over 40, there's 3 risk factors. Caprini score is 3. But when you take a 76-year-old man with cancer, a past history of venous thromboembolism, that's 3 risk factors, but it's a score of 8. You wouldn't protect the woman, you must protect the man. And then finally, I don't want to understand one of the things that even the reviewers don't seem to get, most of them, is the problem of immortal time bias. And that colors a lot of these studies, including the famous New England studies. And yet that hasn't been identified. So what I've rattled on about, I think, are a number of problems that need to be attacked using the current scoring systems with modifications rather than starting over with something new. Remember, the enemy of good is better.
Okay.
Thank you very much. Thank you very much. So now,
thank you.
Now we will move to Brazil.
Yeah.
So I will invite Professor Sueli, say it correctly, to transfer her experience from a country that faces technology and also huge geographical and social barriers, and how we have handled it.
Okay, I didn't think. No, I don't. Yeah, thank you. Thank you very much. Nice to be here. Thanks, Grigorios, for inviting me, and to see some friends and colleagues. Well, I don't have a presentation. Well, first of all, it took me nearly 1 hour to answer the questionnaire, despite they told me that it was 12 minutes. So I had to go back many times. Yeah, but it was very nice and very complete, and I think it highlighted many important issues in the cancer-related thrombosis. So what I have to say from my country and from the public policies in Brazil towards cancer-associated thrombosis is not, unfortunately, the same thing as our colleague from Russia and from Cyprus told us. Because unfortunately, we don't have things in place over there, not yet, at least. And maybe Pedro can help me with something. Pedro is from Brazil as well. So, but we don't have a specific policy for this specific subject. And I think we need to do a lot, not even to do more, but to do a lot over there. And to start from scratch and beginning to implement all those management and prophylaxis tools, because we don't have it in places either in the public and a little bit more in the private sector over there. So Brazil is a middle income country. We have around 220 million people. And 70% of our population relies on our national health service there, which is funded by all the citizens that contribute to the government. So we do have some policies implemented, but not very much for the prophylaxis of thrombosis overall, even for the medical patients that we will start to do it now, because there is just a law enforcing all the hospitals in Brazil to implement committees on thromboprophylaxis.
So I hope we'll follow with the cancer-associated thrombosis. But I would like to highlight two things that in my view, are very important, and they are barriers for the implementation of prophylaxis on this issue. One of them is that we have several guidelines, and this makes medical doctors and people who see the patients very confused about it, because they don't know which ones to use. They don't know which one is better, if we do have one that is better than the other one. So I think the societies should join all together, maybe to give a better kind of message to users on the guidelines. And second, we have, as we shown here, we have several scores, predictive scores, and people also don't know which one to use, which one is the best. Now we have myeloma, and then we have all cancers all together. So the awareness of the use of those scores, and if they are really important, it's a barrier. We need to deliver a very clear message about that to the whole world, not only to middle and low income, but I feel that in high income countries also, this message is not being delivered. So this is two things that I'd like to highlight for this committee to think about more. And maybe to create new scores or improve the existing ones and validate the existing one is some point to debate here. But validation is key, and then it's very important to have the two views on Professor Caprini and also of our colleague that just told us very important things about new technologies on generating scores. Thank you very much for the opportunity. Thank you.
Now I will invite another usual suspect, and guilty probably, because he is working with scores, and he will talk is about you. It's Professor Darko Antic. He is from Serbia, and he did the score for the trolley score for the patients with in lymphoma. And Darko also has the clinical experience in the field. He is in a country where the real field is very hard, and he has the Balkanic concept as myself also. So we can share your experience. And we are working together, and we are good friends since many, many years.
Good afternoon from my side, of course. My name is Darko Antic. I come from Belgrade, Serbia. Also, here is PhD student of Professor Grigorios.
Yes, are very tall people.
Yes, yes. And she is oncologist. I'm hematologist. And
I am hematologist.
yes. What I want to add after this discussion. First of all, I would like to say that my country supported fight against cancer-associated thrombosis, because last year Ministry of Health supported the publication of national guideline for cancer-associated thrombosis. It's very important thing. But what is not good in our country, we don't have support of low molecular weight heparin, as also for direct oral anticoagulants for patients treated for oncological disease. Also, what I want to add regarding your discussion about prognostic scores, I think that we have some, yes.
There is someone with the line.
Please close your microphones. Somebody.
Okay, I think that it's not okay. Maybe without microphone from my side. No, yes, I know. Okay. Yes.
Thank you. In a few words, definitely regarding prognostic scores, I need to say that we will update trolley score for lymphoma patients. We need to give additional biomarkers, and also second team from my clinic developed a score for patients with acute leukemia. I think it's a very important thing because hematological diseases are now in focus. Unfortunately, for example, of course, not only myeloma, but patients with acute leukemia need to be focused more now, especially patients with acute promyelocytic leukemia from my point of view, and also for acute myeloid leukemia of other types. Trolley score is validated internally and externally, and also regarding patients with myeloma, also our third team want to develop some type of improvement of existing scores. That's it from my point of view. Thank you.
I think that there is a common sense. So no borders, but common thinking. This is very important. So since we say no borders, let's go to Africa, north of Africa, Maghreb. So I will invite Muna Sassi. Professor Muna Sassi is a beloved person because thanks to Muna and to two other Tunisian colleagues, we set up our specialized laboratory in Tenon with Ismail El Alami, because they were doing their stage in Paris and they were motivated. So although Assistance Publique was not very
17 years ago.
17 years ago. Since then, she went to Tunis, Sfax? No, Monastir. To Monastir, she set up there the laboratory we had here. And now she will tell us about the experience in Tunisia in the management of the patients with cancer-associated thrombosis. So the model that she developed from obstetrical haemostasis and thrombosis to cancer.
Thank you, Grigorios. I apologize for my bad English. I am a better speaker in French. I will try to speak in English. Thank you, Grigorios, for your kind invitation and for all the committee to invite me to present briefly my activity in Tunisia. We have the same patients, the same cancer patients, the same problems, but we don't have the same conditions and the same economic resources and situation. I started in vitro studies with Professor Ismail Alami in the Professor Gerotziafas 17 years ago, and I keep the same motivation to implement the tools for assessment of thrombotic risk. My laboratory is situated in the central eastern Tunisian and Mediterranean coast, and officially designed as a maternity and neonatal center with approximately 7,000 deliverances per year. And since 2018, it hosts clinical hematology and oncology, medical oncology. So my medical practice focuses on two challenges, intimately and closely interconnected: pregnancy-associated thrombosis and cancer-associated thrombosis too. Our first strong point is the excellent communication between clinicians and biologists. I'm a hematologist, a biologist, and it is very important. It's a big thing for me, the fact that since 5 years, I was authorized to conduct specialized hemostasis consultation. And if you, in Tunisia, there is only 2 hospitals with such specialized consultation. I'm the second center, and I am, je suis contente. I'm happy. Since 5 years, we conduct 222 consultation, specialized hemostatic consultation, with 70% thrombosis, cases of thrombosis or placental vascular mediated diseases, 25% of bleeding disorders, and 50% antithrombotic drug management. The median consultation duration is 30 minutes. There is two types of consultation, initial consultation or follow-up, which is generally shorter. Median number of patients per day per consultation was 7. It ranges from 5 to 11 patients. And I try to use assessment tools, thrombosis and bleeding risk scores, different scores, pedigree analysis, and especially patient educational resources. I try to develop flyers in French. French is our second language. It's our official language in medical courses. But for flyers, we try to develop resources in Arabic, and especially in our dialect, because our Arabic dialect is different from the written Arabic. And it differs in all the Arabic country. So we try to be near to our patient. Finally, this consultation illustrated a collaborative, patient-centered approach and shared responsibility for patient management. Our laboratory have specialized equipment in team motivation. Our panel include thrombophilia testing, acquired and inherited thrombophilia testing, dimer, fibrinogen, anti-10 activity, thromboelastic tests, bioroten analysis, and platelet function by light transmission aggregometry. So we tried to document the hypercoagulability. I'm keen on thrombin generation. I think that thrombin generation is have more valuable information than viscoelastic tests. But thromboelastic tests are here for postpartum hemorrhagia. Donc I try to use it for hypercoagulability. And then for platelet function, I don't have a specialized marker for platelets, but I have a light transmission aggregometry, and I try also to use it to document the hyperactivity of platelets with the reaction with different and low concentration of platelet activator. So I think strongly, I believe that each cancer is different, that each cancer have its own and distinct proper signature. Grigorios says fingerprint signature. So defining this signature more properly, more precisely, will allow us to pave the way to personalize the management of cancer-associated thrombosis. I will continue to develop tools to personalize treatment of the treatment and the choice of anticoagulant for each cancer. What we would like to do in the future: to implement systematic thrombotic risk assessment and diagnostic with periodic reassessment, because the risk of thrombosis is dynamic, and the evaluation, the assessment must be continuous, because the risk factors are different to identify patients with hypercoagulable states and to personalize anticoagulant antiplatelet therapy. Our main limitations are the limited and insufficient use of risk assessment scores, the incomplete sharing of medical records, the lack of reimbursement of direct oral anticoagulants, and the continued use of VKA in cancer patients. That's all. This is my team. My team is our last picture from the last anniversary of World Thrombosis Day in October 13. And since 2017, we tried every year to celebrate World Thrombosis Day to raise awareness about pregnancy-associated thrombosis and cancer-associated thrombosis.
Thank you.
Thank you.
Yeah. Well, I think it's quite late now. We have covered most of the questions that we asked in the beginning. Of course, we will elaborate a little bit better now the analysis of the survey that has been performed with the response to the questionnaire, and of course, we'll circulate the results between all of you. Also, if possible, we will also put on the website the presentation that has been done today, if it's possible, if it is available. Also, a brief summary on the ICTHIC magazine, that is ICTHIC.com magazine. So you can try to sum up what is the results of this afternoon. I think that is very nice to have had this brainstorming together. And I hope that new ideas will help, but at least we can grow as a network and work together, staying in a field that makes us united and not divided. So, which is the better thing that we can do for the future in general, and can make us to feel better in these days that are not always very nice from this point of view. Thank you very much for staying today with us, and hopefully we can stick together for the future. Thank you.